the hospital CEO for Northampton in due course. I also need to welcome and introduce John Evans, because this is his first public board meeting since joining the group in the 7th of June, which seems a long time ago. And we also have to welcome Teresa Latang, who's Group Communications and Engagement Director, whose first board meeting it is also. And we have a number of mentors, mentees, reverse mentors, and whatever will be attending for item 11, because board members had some reverse mentoring in place for the last few months. So that's all from me. Any declarations of interest, anyone? No, thank you very much. The draft minutes, the public board meeting on 27th of May 2021. Are you happy to have a fair record of the meeting? Yes, good, thank you very much. And the matters arising in the action log, which if you give me a few seconds, I'll find. Are you happy? Is there anything there that you want to raise in the action log?
Just to update the board, Alan, that the Emergency Preparedness Annual Report will be presented to either the September or the November board meeting, dependent on when we get the notification from NHSEI.
Okay, anything else at all from anyone else? No? No, fine. And we're over to staff story, items 5, and I can see our visitors are here already. Please introduce them, Sharon, and off you go.
Thank you very much, Chair, and it gives me great pleasure to be able to invite 2 of our members of staff, 2 of our midwives, to our public board meeting today. Our midwives, Sam and Fatima, are going to share with us their story, the story of BAME leadership and their story of developing continuity of care within our maternity services. So I'm not going to say any more, but with immense pride, I hand over to Fatima and Sam to tell us their story.
Thank you, Chair. My name is Samgeliso Sibanda. I'm a midwife in Northampton. I'm a continuity of care leader in one of the teams of continuity in Northampton. I am also a co-chair of the REACH network at Northampton and currently on the aspiring BAME leadership course for Midlands. I am very happy to be here today, bringing myself with my colleague Fatima.
Hi, good morning, everyone. I'm Fatima Zaragaush, and I'm one of the continuity of care leader.
Today, we are going to talk to you about leadership that we have done. In many cases, it's been said that leaders are born, or some people do say leaders are made by good leaders. Today, we are here to just showcase our work, which we've done over the years. I am from Zimbabwe by birth and have been to Zimbabwe to showcase the education that I got in England, just to try and save one baby and one mother in maternity care. So I set up a program which is called Below the Life Project, which takes midwives from Northampton Hospital, doctors from Northampton Hospital, domestic people, workers from Northampton Hospital, anyone who wants to come to Mbilo, I'll open this invitation to the board today. So what we do at Mbilo is go and help in terms of maternity care, go and teach the skills that we have to save those moms. It is well known that in the African countries, the mortality rate is a lot higher than everywhere else. So over the 8 years we have gone, a total of 16 members of staff of Northampton General Hospital have been out there and worked as part of a great team of personnel and taught lots of skills. And yeah, next slide, please. Sorry. Okay, what have we done in Northampton? We are a team of midwives that have Northampton has set up 4 continuity of carer teams, where I lead in one of them. Fatima leads on the other one. Why continuity of carer? Okay. Better Beds is a review that was done for women to show, and it showed that women would benefit from continuity of carer, or they wanted continuity of carer in their journey through maternity. It is well known that women from a BAME background suffer more in maternity, or they end up with really bad outcomes in maternity, and people that live in social deprivation. So we have gone and answered to the Better Beds call and set up maternity continuity of care teams that look after women that come from the BEM background. So why continuity of carer? Continuity of carer does suggest that each woman will have a consistency of a midwife or clinical team that looks after her, have a named midwife who is responsible for their care all the way through the pregnancy journey, who will coordinate their care and at least provide 70% of their care. They should have a midwife that they know at their birth. This is the biggest part. They need to know the person that's delivering their baby. They should be enabled to have a relationship of trust. So knowing your woman makes the woman have a relationship of trust with the midwife. And the aim or the trajectory is that we will have 100% of continuity of care by 2023. Well, that's the national trajectory. We are working on that. Next slide, please. Why BAME? Why do we prioritize BAME? It is well researched and well known that women suffer a lot of bad outcomes in pregnancy. The Embrace report of 2018 suggested that Black women are 5 times more likely to lose their life or to suffer pregnancy, or to lose their lives actually during the first year of the birth of their child, or during labor, or during maternity care. It is also known that Asian women are 3 times more likely to have these bad outcomes. So that's why BAME has been prioritized. And the reasons for this could be very complex and could be very, very different from one woman to another. There is a lot of talk about lack of understanding of the services. I came from Zimbabwe myself one day as a woman that wasn't in healthcare. I did not know how to access healthcare. I did not know where to go. Had I been pregnant at that time, would I have known that I needed to book early? Maybe not, because that's not the practice in Zimbabwe. There is things to do with poverty and domestic abuse. Poverty, we have found since we set up these teams, there is a lot of poverty around people who come from a BAME background in Northampton. People, when they go out to meet professionals, they will dress up, they will have makeup, but they might not have had food at home. So poverty and domestic abuse, which is a very hidden thing in our society. So I'll pick on fear of being charged by the system. If you are not from England, or if you don't belong to England, you might have to pay for the NHS. People will get pregnant and not register because they don't know whether they've got to pay or they don't have to pay. So that's another thing. One big one we found is language barriers and cultural barriers. It's a good thing that we have been involved in training for building cultural bridges so that people can understand cultures from different women's perspective. Next slide, please.
So what we have done so far we launched 4 teams since November 2020, and 61.4% of the women being cared by our continuity teams that are from our diverse communities, and 38.5% the women from social deprivation. Looking at the first quarter of the 2021, we delivered so far 264 babies, and 99% of our women, they had their named midwife providing at least 70% of the care. We had 200, I think I can say more than that now, new bookings, and our breastfeeding initiation rate is amazing, is 90%. We hope by the end of the year, we can look at our new data and see what are the outcomes and what are our improvement. Next slide, please. So why continuity? Why we are so passionate about continuity? Why we think is our opportunity? Because through continuity, we can create spaces of welcoming and listening to our women. We can create relationships based on trust that is allowing us to identify where is the problem, where is the need, there is any fear, any anxieties, any stress, and in this way we can set what are our solutions. We can reduce health inequalities through the work of proportional universalism, where we focus on equity more than equality. And as some already mentioned, language mediation. We are really focusing a lot of language mediation. We are focusing on providing education for midwife, in particular cultural competence and awareness. This is our main focus at the moment. We are trying to challenge racial and cultural bias within the system and encouraging people to be conscious about their unconscious bias. Next slide, please. what our women are saying so far, we had amazing feedback from our women. Most of them, they're putting a lot of emphasis on the communication and support they received. As someone said, I felt very supported and listened to. It is what we want. We want to give voice to our women. And someone as well said, I particularly love the idea of continuity of care, as I believe that this will support and contribute to improve quality and safety of maternity care, especially for moms to be within the babe who have higher chance to experience preterm birth. Next slide. So these are my final slide. I want to say thank you. I want as well to say that we've been shortlisted for RCM Award for 2 categories. Our community teams have been shortlisted for the excellence in maternity care during a global pandemic, and our continuity teams have been shortlisted for race matter. Thank you.
Now, thank you. We have finished our slide. Is there any questions?
Thank you very much. Very impressive, very interesting as well. Questions, comments, or anything else from anybody on the board? Where am I? I'm sure Jill has a comment. Yes, I thought she would. Jill.
Thank you, Chair, and thank you, colleagues, for a very good presentation, and you packed a lot into a very short space of time. I actually had the privilege of shadowing Sam at the beginning of the month, and I attended a bump to baby session with 14 mothers from the continuity of carer team. And I spoke to all of these 14 mothers, and the comments that came back, particularly from women who'd had babies before, and said how different it was and how much better the experience had been as part of a continuity of carer team. So I just wanted to echo what my colleagues were saying in terms of feedback. And secondly, what they probably didn't have the opportunity to mention is that they're working with the Charitable Trust to look at potentially having a Moses Basket package for these women that are in such dire straits, living in poverty. So colleagues have found when they visited the women that babies were potentially wrapped in tea towels and didn't have any nappies, for example. So they've been working with the health visitors on with this too. So well done, colleagues. Keep up the good work.
Thank you, Jill. There is a charity in Northampton. Sharon will talk about it, because we had a long conversation with them a while ago at National or International Nursing Midwives Day, who collect Moses baskets and other things for people, and it's very, very active, I think, in Northampton. It doesn't exist everywhere, although it's a national charity.
Is that Home Start?
No, Sharon, help. I can't remember the name of it either.
It's a hospital and the Northamptonshire Healthcare Charity, and absolutely can work with them and other partners to see what it is that we can do.
Thank you. Simon.
Thanks, Helen. I thought that was an extremely impressive presentation, both of you. So I just wanted to say that to start with. I was especially impressed by getting a reference to universalism and Marmot in first thing on a Thursday morning. I thought that was absolutely ace. Thanks. But, you know, one of the things I want you to feel able to do here is to say, what do you need from us? What can we do to help you? Because, you know, the work has only started. It's very much ongoing. As a board, we know that the maternity agenda is very live for us. It's something that we spend time thinking about. In fact, I just met with Jill this week to talk about it. So I just wanted to give you the floor to say, is there anything practical that you think we can do as a board to help you? Whichever of you would like to respond to that. Thank you again.
Fatima.
Now, regarding this, I think me and Sam, we discussed it a lot about training, because as I mentioned earlier, I think training for midwife and staff regarding cultural awareness and competence, because I think to provide a quality of care, our staff need to be educated, especially when you look after diverse communities. So if we can put more emphasis on that.
Okay. Thank you very much for that. Mark, I thought you might respond to that.
Thank you for being stereotypical, as always. Thank you. That was a fantastic presentation. And as you both know, we are rolling out the Building Cultural Bridges programme. It comes up later on the agenda when you'll be back again as reverse mentors for that particular item. And I think perhaps we will need to consider that under that particular item. So I know we're looking at 5%, so 500 colleagues over the next year to be trained in that particular programme. But I wonder, rather than 500 colleagues, which is important, it's probably important for us to work out which areas perhaps we would focus on first, given the severe consequences and outcomes potentially that patients may area, as you've described and discussed. So that's something for us maybe to hold on to in our debate a little bit later on today. And I just wanted to say a massive congratulations for the RCM shortlist. You know, that's an amazing achievement. It was almost like the last slide and we moved on, but Fatima, you should be very proud, you and Sam, in terms of that nomination. And we look forward to the end of October and finding out what the outcome is. But being shortlisted by itself is a fantastic achievement. You think the number of midwives in this country, the number of award submissions, and there you are flying the flag for the service in which you provide, the care that you provide, and of course that for NGH. So thank you very much.
Okay, anybody else at all? No? Okay, thank you very much. Okay, ladies, I thought you've heard it already. I thought that was an excellent presentation. It was very impressive. I spend a little bit of time nudging our executive to enter for awards and so on. I think it's very important for the recruitment and retention and pride of the hospital. So congratulations on that as well. And it's the kind of thing we need to do to keep raising the standards of what we do. So thank you very much for your presentation. If you are back later in the reverse mentoring, even better. But thank you very much for your time this morning. And I'm sure Mark will be responding to your comments, Fatima, about what the board could do. Thank you.
Thank you, Chair.
Thank you.
Right. So item 8 we're on now, Chairman's report. Well, I suppose, first of all, we ought to congratulate Amanda Pritchard on being appointed as the new Chief Executive of NHS England, which in due course will include NHS Improvement, assuming Parliament agrees. First woman in that role. Everybody says since 1948, but we didn't have any until about 1991 chief execs, so it's a little bit shorter than that, but nevertheless it's quite a remarkable achievement. And looking at the congratulatory messages coming in on the Chairs Network, it's obviously an extremely popular appointment. The second thing to do is nearer home is congratulate Naomi Eisenstein, who has been formally appointed to chair the ICS board going forward. She was an interim appointment in the sense that it was a shadow form in the healthcare partnership and now moving forward into the ICS. And she has been one of a number of ICS chairs who have been appointed on a substantive basis. Others will be going out to advert in the not too distant future. And that then takes us in due course sometime during August, September to the appointment of the Chief Executive of the ICS. So congratulations to both of them. I'm going to ever so slightly steal Aileen's thunder about building a new entrances on this one. He states, Stuart, the new front entrance opened and you know, I've always thought Northampton's a bit strange. It's the only hospital I've been in the country for years that didn't have a Costa. And Costas are a very important part of non-execs finding out what's going on in their hospital, says he. You can listen to patients, you can listen to staff, you can talk to staff and patients about what's been going on. Looking at the queues, it's just suitably socially distanced for M&S and Subway and Costa and whatever. It's been a hugely undersized venture in the end, Stuart, probably, but it was very, very welcome. But it's on top of that, we've got the paediatric ED opens, I think, next week, Aileen, after a bit of a long haul, but due to open on Monday next week. The new ITU, which is well advanced and is really a remarkably big, well-designed space, will open before winter. So, you know, those are significant things that we took a few risks as a board on in terms of funding and in terms of pushing forward with them as we were still searching for approvals and funding and so on. So all of that is to be commended. Well done, Stuart. But beyond that, there is a request from NHS England for expressions of interest for the next round of the hospital infrastructure programme. I'm not meant to call it HIP 4, but it's something around that level, but it's about major reinvestment in hospital infrastructure. And Northampton has been, well, invited to apply would be slightly strong, but asked why they're not applying would be probably too weak. So it's somewhere in between those two phrases. So we will be putting together, I'm pretty sure, some sort of bid for that. It does require quite a bit of work on the hospital development plan, on the strategic estates plan. And many of you know that Polly Grimmett from Kettering has been working across the piece looking at strategic estates in the group along with Stuart. So we will be doing our very best to put forward a bid to get Northampton on the same track, albeit slightly further back than Kettering is with their HIP 2 program. And it's obviously very important for Northampton to get ourselves on that plan and get a coherent site development plan, strategic estates plan. So that's that from me. Any comments on any of that before we move on to Simon? Nope. Simon, over to you.
Thanks, Alan. A few things to reflect on. It's just nearly a month since we launched the group, and I just want to go back to that day and as I start my comments and just reflect on and thank everybody who was involved in the day. Firstly, those days are huge efforts to put together, and I was on the Northampton site that day, and I know that when I went out there, people really enjoyed and resonated with the experience of what we were trying to convey on the day. I think it's particularly important to highlight the fact that what has resonated a lot with people, and a subject to which we'll be returning a lot in the months ahead, is the university hospital status, which we made the centerpiece of that day. And I'd like particularly, loads of people played a part, but to thank Teresa and the comms teams for the immense amount of hard labour that went into that day. It looks easy on the surface. I know it's anything but underneath. And then finally, just to reflect on that thing, but those days, they're a bit like a firework, and to mix my metaphors entirely, we now start eating the porridge, and the porridge is kind of building the coherence around the new values set, and we're going to all be doing that patiently and incrementally over the months ahead. But big thanks to the comms teams to start with. Challenges. I thought I'd use this halfway point in the year to reflect on kind of three things that are really quite important. Could have picked a number of them, but these struck me as some of the key highlights. So the first I've talked about is elective recovery. And if I'd have been talking about this just a few days ago, I might have been framing my comments in a particular way, but we're talking about, I wanted to particularly talk about it this morning in the context of extraordinarily high and unrelenting non-elective demand. And that has we are, if ever we were doubting that we were seeing a bounce back from COVID, we should doubt it no more. We're in the kind of teeth of a fierce winter in the end of July, and that's a reality that we're now dealing with. We're keeping elective surgery going, but the balancing act of managing to do that and also managing the non-elective demand that we're seeing is and will continue to be a real challenge. I was particularly pleased this week, and Alan and I were particularly pleased to welcome Naomi to Kettering, and we'll be inviting her to Northampton. And she saw, as our new ICS chair designate, directly for herself some of the pressures that non-elective demand can put upon a hospital. And I think it was important that she saw it. And I think, Alan, it would be fair to say that she walked away from that, I think, with a new appreciation of what having a really hot hospital looks like. I also wanted to signal that one of the things that we will be doing as we develop our IGR over the months ahead is to start to bring forward into that some of the theatre efficiencies data. Theatres are pound per square foot, to go all imperial on us, myself for a second, are the most expensive pieces of real estate a hospital has. And it's right that we should make sure that we're using them as well as we possibly can. And particularly given the national context of elective recovery, we're going to be asked to demonstrate, as we should be really, to ourselves, to our public, regionally, nationally, that we are making the best use of the precious resources that we've got in our theatres. So I'm signalling that development in our IGR, and perhaps we'll be coming back to that later as we think more about that. So just want to thank again, as ever, the ops teams for all that they're doing to keep that non-elective pathway safe, and thank our partners too, who are really doing their best in West Northampton to try and help us this morning, and perhaps Eileen will return to that when she speaks. Second thing I wanted to highlight is obviously the ongoing work around the ICS. I think we can now pretty much safely say there is a settled direction of travel, and approximately in April next year we will have a new system. That represents a huge opportunity, because all of us who've lived with the consequences of the kind of commissioning system over the last 10 years or so have commented upon the various issues that that has thrown up. But the opportunity is not going to be easily won. It takes quite a lot of effort to get the right system, but it's important that we put that effort in, because the issue will be that we will live with the consequences of those choices for the next 10 years. It's rare, you know, that you make decisions as boards where the consequences have that level of time life before they expire. So Karen, who's leading for that work on us, is out there putting our views forward, and today as a board we'll be asked to sign off the direction of travel in our public board, which really points to some of the kind of key core design principles that will inform the development of our system. So an important conversation there, and thanks to Karen for all the work that she's doing on that. And then finally, from my report, I obviously want to highlight the work that we're going to be reflecting upon today on our equality and diversity strategy. We are a multicultural, multiracial, multi-faith community in this hospital. And as we are a community of those many different backgrounds, so we need to continue our journey of becoming a more inclusive employer. Some of us, I included, have had the privilege of having a reverse mentor over the last nearly a year now, and the privilege of having a glimpse into people's lives is one that cannot be overstated. And the amount of personal sharing that I have benefited from and what it has made me think about it is immense. And I want to take the opportunity to pay tribute to my reverse mentor for putting up with me, Rita from the practice development team, and also give us an opportunity today just to say, let's reflect all of us as we go into that debate about what each of us can do personally and collectively to make our organisations more inclusive places to be. I think what I've learned is we've done a lot. That lot has been recognised and it has started to make a difference, but there is still a huge amount for us to do, and that should be the focus of the conversation today. Thanks.
Okay, I'm going to move straight on to Aileen, and then we'll pick up any points anybody wants to pick up at the end of that. Aileen, please.
Thank you, Chair. So obviously, I'll start with the good bits, of which you've stolen some of my thunder around the front entrance. It does look fantastic, and who knew you could spend that much on coffee and sandwiches, as we all did in the first week, I think. So a great addition, and as you say, well done to Stuart and the team, and also our partner contractors who did really have to work very hard towards the end. So I encourage, and it's air conditioned, so I encourage everybody to go down there, especially on a hot day. A couple of other bits of news which are very positive. We have appointed 3 new ED consultants in the last few weeks, one post is shared with ITU. Really good calibre of candidates, and my goodness, we need them. So very pleased about that. And also we have appointed Tracy Robson as our substantive HRD for Human Resources Director for NGH, and she starts from the 1st of September, picking up from Bronwyn. Tracy, as you know, is already in the organisation doing something else, but we went out for a competitive process and it was very competitive indeed, but Tracy won the day, so congratulations to her. Going on to the less positive things, we know that we have got a background of rising COVID, particularly around Northampton and Northamptonshire, and we are seeing some of the effects of that. Today we have 45 inpatients with 3 in HDU here. It could definitely be worse given some of our background infection rates, but that, I guess, shows that the vaccination is working. So we are still encouraging everybody to have double vaccines, but it is definitely presenting us with some operational pressures, not just because we've got red wards now on the site, but also because it's, of course, we have a local population of staff, so it's affecting them too. And you've heard lots in the news about the pingdemic. We are not immune from that. So Sharon and her IPC colleagues and a number of other operational colleagues now have a daily panel to look through the individual circumstances of those that have been pinged, to work out whether they should stay at home or whether actually on balance of risk it's okay for them to come into work if they are within an essential area for which the risk would be greater if they didn't. So it is definitely a challenge, and as Simon said, we are almost in August, and this feels like the worst winter that we have been through for a while. It's not just the COVID pressures, in fact they are just something that complicates things. We are seeing a lot of admissions, even though our conversion rate is gone down. It's low, and it's, you know, we were benchmarked nationally. We would be coming out very well on that. So we're not admitting to decide, which is good, but we are tight. And Simon also referred to our partners who are all in here today, this morning, trying to help, because we have had 10 very difficult days and we start this morning in a difficult position. So it's not that we don't have engagement, we definitely do. But of course, social services colleagues and our community colleagues would also say that they have got particular staffing issues and some issues around our local nursing and residential homes who've had to suspend admissions. So all of that paints a very tricky picture, both busy at the front door and also a little bit slower around the back of where we can move people onto should they need continuing care. But it's a great effort by everybody. It's amazing in adversity how our staff step up. They have been, and they will continue to do so, but it is it's quite pressured at the moment. So I'm usually an optimist and I know we'll get through this, but I think we must recognise the impact on our staff. But good efforts all round, and thank goodness we have a selection of coffee, cakes, sandwiches and all sorts of confectionery in Marks and Spencer's they would want me to tell you, and pop over to the stock shop should you wish to buy a caftan. Difficult but good, and our staff continue to amaze me, actually. Well, not amaze me, I would expect no less, but thanks to them for all of their efforts. So that's about it for me, Chair, really.
Okay, thank you. Anybody want to pick up on any of that? You don't need to talk any more about Costa and coffee or anything else. It's all done. All right, all done. Move on. Right, thank you. Yeah. Thank you very much. Okay, integrated performance report. It continues to be the Eileen Doyle show.
Just for a very short while, Chair. So going on to the integrated performance report. So that's partly why I didn't go into any more depth in my brief. So we'll go through with our exec colleagues for their particular portfolios. If we could start with Matt, please. Medical Director's report.
Certainly, thank you. And I will, of course, take it as read. And I like simply on 2 points, if I may. To highlight, so first of all, in relation to the fireworks in Simon's Porridge, the university status for our hospitals in the group and NGH has created a real positive buzz. Everything that we could wish for at this stage, certainly amongst the senior medical cadre at the hospital. whether it's on the WhatsApp groups, whether it's in consultant interviews that Eileen's just been referencing, where the external candidates both mentioned the university status as one of their reasons for applying to the hospital, whether it's in drop-in sessions or consultant briefing sessions. It is being talked about and the implications of it and what it means and how they can take advantage of it. So it's feeling like a very good thing to have done. And as Simon says, it's now the hard yards of delivering the benefits on that, so that it's more than a brand. Moving on to the theme running through today's public board meeting, I'm delighted to say that the excellent work that Toyosi Adeniji has done as the BAME Clinical Fellow at Northampton General Hospital, a position which she is going to continue even as she takes up a partnership in a local GP surgery. We're able to expand that work, having worked with the GP head of school for the East Midlands Heme Deanery, and also the University of Northampton, and my counterpart Rabia up at Kettering General Hospital. We're going to be appointing a series of GP training posts to leadership development with a BAME theme, so that we can continue to embed the work, but has seen satisfaction and recommendations of Northampton General Hospital as a place to work for international medical graduates over the last 18 months rise from 30% to 80%. But as Simon says, there is so much more to do, so we're delighted to be able to land those posts in this hospital and in the group. I have nothing further that I wish to bring to the board. Thank you.
Come off mute. Thank you, Matt. So just going on through the report as it runs. So back onto the Chief People Officer's overview, please, Mark.
Thank you, Eileen. Similarly to Matt, I won't go through the whole entirety of the detail. People will be pleased to know. Just to focus on the context in which Simon and Eileen have described, the hospital is extremely busy. We are in what we would normally see as a difficult winter, and that's on the back of 18 months of already challenges for our colleagues and our staff across the hospital. So that is being reflected in our sickness absence position. I'm sure you see that and note that in the SPC charts that you can see in the contents of this report. We were generally running pre-pandemic at 4.5% in terms of sickness absence. It's now more in the 5 and 6% sickness absence position, which is obviously having an impact. And that's obviously in spite of all of the work that we've been undertaking in terms of health and wellbeing that we've supported both locally across the group and indeed across the entirety of the system, which is highlighted and referenced in the report in terms of our recent virtual health and wellbeing festival. So there are a challenge, we don't give up. Just as Eileen said, our staff continue to work incredibly hard, and therefore it's important that we continue to support them in the same way. And we are seeing some signs of in terms of substantiation of that stuff in terms of the International Nurse Recruitment Programme. You know, it's a huge testament to Sharon and the team. Sharon leads us work on the part of the whole system, and we are seeing our international nurses start to arrive. They are starting to embed themselves in our organisation, which is fantastic news to see, and so may it continue, because they are providing a fantastic service for us. I think one of the challenges that we have, therefore, in terms of this temporary staffing position, in terms of the sickness absence that we talked about, we know our challenges in that particular area, and we're working on that closely in terms of how we can reduce our temporary staffing expenditure whilst maintaining those services that we have already discussed. In terms of the rest of the report, I wasn't going to focus too much more, because pretty much the agenda is dominated by people aspects of the ED&I strategy, and indeed the disciplinary policy, which are referenced here in the content of this report. And of course, a version of this report went to the People Committee on Monday, so I'm happy to take any questions.
Doesn't look like there's any hands going up just yet, Mark, so people may come to it at the end. So in the spirit of keeping moving, if I could invite Sharon, please, with the Director of Nursing's report.
Eileen, and there are just a couple of points that I would like to raise from my report. I'd firstly like to just share with the board the fact that our nursing, midwifery and allied health professional strategy, which was passed last time by our NGH board, has also been passed by our Kettering board as well. So Leanne, my counterpart, and I are very much looking forward to launching our joint group strategy toward the end of August, beginning of September, to give our nurses, midwives and allied health professionals a real direction for the future. I'd also like to share the fact that we have submitted our evidence by the stated deadlines for compliance with the identified Ockenden standards, and we've submitted full compliance with our clinical negligence scheme for trust safety actions. And for both of those, we are awaiting feedback on the outcome. And lastly, infection prevention remains an absolute priority for us and our COVID response, which our Chief Executive has just referred to. We're continuing as a team to work absolutely flat out, looking at how we manage our response to the third wave. We're currently sitting with 45 patients in the trust, which is a step change from the last 7 to 10 days. We are also reacting very speedily to guidance that's coming out nationally. We have established a ping panel within the last week, so that's picking up the COVID positive contacts that have been picked up through track and trace, and seeing whether what the appropriate action is to take for those members of staff as to whether they can return to work or whether they have to isolate. And my final comment is just to thank all of our staff and our visitors for their continued support during this difficult time, their continued acceptance of the need to adhere to infection prevention guidelines, space, face, hands, etc. Thank you.
Thank you, Sharon. I'm sure, like I say, there may be questions at the end. So moving on to the Chief Operating Officer's reports, and I'm afraid you've got me today because Joe is out, and I'll try and do it justice, but I'll take it as you read that you've all seen it. I mean, I think the highlight messages are our numbers have increased across the board really in terms of what's coming into us. So our 4-hour standard for the month reporting, it was 86%. It's probably going to be a bit lower in July for a number of reasons, but that's a backdrop of increased attendances of about 1,500 from previous month. So it is busy. As I said earlier, our conversion rate has not gone up. In fact, it's gone down, but of course, you know, statistically, it's probably stayed about the same. It's just higher numbers coming in. We've extended our Springfield hours to 2 in the morning because our busiest period is still tea time and the twilight, just to make sure that we've got an alternative to A&E to stream patients over to Springfield. Our ambulance conveyances have decreased slightly for the month reporting, but have increased again during July, which I'm sure will come through. The big focus regionally is on ambulance handover delays. I'm pleased to say that NGH does quite well. We're probably best in show, but the downside of that is when others are in difficulty, we are asked to help, and we do our best to try and do that, but of course we have to assess our own risk and safety at the time. But some of our surrounding trusts, not Kettering, but our other surrounding trusts have experienced really, really long delays, and we are fully aware of how difficult that is for patients and the staff. Our attendances in the, as I said, our busy periods of each day and the weekends are our twilights and tea time. Stranded and super stranded, I'd mentioned earlier that our colleagues, our partners are struggling with what's out there in terms of moving people on, and that's reflected in our numbers. So for the month reported, our super stranded numbers were on average 89, which was an increase from the month before. As we sit here today, there are 113. They were 125 4 days ago. So it's going the wrong direction, and that definitely places stress on the entire system, I think. So everything has slowed down slightly. The key to it, we believe, going forward, is to increase the expansion and hours of SDEC. SDEC is the same day emergency care service. We've already moved it out to midnight. I think that probably needs to go a little bit longer. I don't think it quite needs to be 24/7, but it does need to be up to 2, 3 in the morning, just to clear that backlog, so that people have an alternative to being admitted to a base bed. And we are seeing increased numbers of people coming through with what we would call frailty indicators. So we do need to make sure that we are doing our best for that group of patients who, by their very nature, are frail and vulnerable. In terms of moving on then to cancer for the reporting period, we continue to do reasonably well at cancer. However, we have a couple of pinch points. As you know, we have an increased number of referrals. Our 62-day standard is always the one that we find the most tricky, and it doesn't take much to fall below the standard, but we continue to work really hard to make sure that we've got consistency with that. Gynae, which was one of our hotspots, are doing better. And you should see reflected in next month's, the next board report that they are recovering, as it were, but we are still struggling around oncology. And I think I'm sure Matt would agree with me. I think of all the things we worry about, it's making sure that we've got enough oncological support. Even though we have taken colleagues on, it's a very, very busy service. 52 weeks, obviously. You'll remember that we were heading towards 4 figures at the beginning of the financial year of patients waiting. I think we were at 800 or just shy of 800 in March. As we sit here today, again, things have moved on from the report. We're at 170, so the teams have done remarkably well. There's a combination of, at the beginning, it was around validation to make sure that people still actually needed their procedures and hadn't been done or done elsewhere. But actually, the decrease thereafter was just processing the patients and making sure that we got through the backlog, because it's never nice to wait. And similarly, we had some significant backlogs around diagnostics. Echo, if you remember, we had around 1,800 patients waiting for their echo, which is always, those are not a group of patients you want waiting ever. And the team have worked really, really hard, and those will be cleared right back by the end of August. So phenomenal effort on their behalf. All of our theatres back up and running. There is, as I think colleagues have talked about earlier, there is a theatre efficiency programme, which is part of the whole sort of transformation and efficiency piece of work, to look at how do we maximise the use of our resource to make sure that we are minimising waste, because it's a precious and expensive resource, and we want to make sure it's running as functionally well as it possibly can. And just mentioning around unappointed, the unappointed issue which popped up a couple of months ago. We obviously have a task and finish group on a daily basis. We talk to Simon regularly, Debbie and I, from both organisations. And for NGH, we have decreased our unappointed follow-ups by 31,000. About 5% or just shy of 5% need referrals, need an appointment. They've all been booked, and we are assuming that within our current capacity. So we are just working our way through those sequentially and applying the rules and contacting patients to see where they're up to and are they doing okay. And as I said, I mentioned around diagnostics, we do have another mobile CT that arrived, I think, last week or thereabouts, to just make sure that we could use our diagnostic services to our best advantage, to make sure that people are getting appropriate treatments and not waiting any longer than they need to. So that is sort of an abridged version of what Jo would tell you if she was here today. So any questions around the IPR? Thank you.
Sorry, David.
David?
Yeah, thank you very much, Alan. One question, Eileen, and I suppose it kind of refers to what Simon was talking about earlier about the theatre efficiency programme and what you referred to also. What are we doing with the independent sector? Discussion around the independent sector seems to have gone a bit quiet from where I'm sitting. Are we still engaging the independent sector in assisting with our elective backlog?
We are. I think we are. They've got waiting lists of their own for private patients, so I think our access to them is less than it was when private patients were suspended, if you like. But we are still working in partnership, and Northamptonshire is a heavy user of the private sector, and we build that in as part of our overall capacity plans, because we couldn't do without them, although we probably use them a little bit less than we were, but in a much more planned way. So it's not sort of, we try to avoid ad hoc, short notice, can you please help us out? Those days are gone, really, but we are still using them, definitely.
Thank you. And if I could just have a further question, Alan. About a year ago, we were talking about occupancy rates and how the target was for 85% occupancy. Is that still a target?
It's still a target. We haven't been at 85% for quite so well, probably since end of wave one, really. If we were at 95%, I'd be a happy lady today, but we are full, and we operate in that last 5% for most of for each day, really, for our new admissions. So our aspiration is still 85%. It should be 85%, and going into our winter planning, that's what we're aiming for. Otherwise, things just get, the more congested we get, the less efficient we get. So, but that is still the target, yeah.
Thank you.
One of the more interesting places that non-exec directors can visit to see how hospitals works is the control room, or the whatever it's called in different hospitals, but it's where all that bed state planning is done and who gets to go where and how it works. And it gives you a real sense of the complexity of it. And I know Andy Callow will say we're developing an AI system to think our way through that as part of a bit of a national pilot for it, but it is the most enlightening place to understand the actual manifestation of the pressures Aileen talks about. Denise.
Mine's a quick question for Sharon on the complaint side of things. So it's good to see that we're turning around the complaints, and I've obviously got an interest in this anyway. But in terms of those that are still outstanding from the wave 2 COVID, where we increased the turnaround time, I know you incorporated into the report and just said we're still working our way through these, and that they're being prioritised. But some of these people have been waiting a long time now, Sharon. So have we got any idea of sort of numbers now of how many are still outstanding? How quickly can we deal with them?
Thanks, Denise. I understand the reasons why you'd be asking me the question. So what we have done is we've been in contact with all of our complainants, so they know exactly where we are at. We've negotiated with them a timescale for completion of their complaint, and that's been accepted by them. And that's exactly what we are working to. But in addition, any new complaints that have come in over and above that, we are working to our original timescales, which are between 20 and 40 working days, and we are achieving that. I don't have the exact figure in front of me at the current time, Denise, but I'll happily share that with you. I'll obtain it and share it with you after the meeting.
Fantastic. Yeah, we'll take it offline. Thank you.
Thank you.
Anne.
Thank you. Just a quick question for Matt on the serious incidents. So we had 8, and it's good that they're being reported. I just wondered if you can tell us how we're sharing the learning from those incidents across the hospital and the trust.
Sure, thank you. So there is a well-established process for sharing the learning, which we have continued to follow, although we moved into COVID light at various points during the pandemic response, not least because quite a number of the clinical governance team had essential skills, which at times of peak demand and staff shortages were better deployed to direct patient need. But we have always kept the SI process running, and the learning is then translated into recommendations and then actions which are agreed with the requisite clinical areas, or indeed back office areas where appropriate. And then there is an assurance team who tracks progress against those actions. Sometimes those actions, even though agreed as appropriate, both by those responsible for delivering them and the corporate functions responsible for their oversight, and that they attend to the actions, the required recommendations appropriately become obsolete. A good example being that clinical audits that are required in situ to confirm that actions are completed was not an appropriate thing to do for infection prevention and control reasons throughout the pandemic, and for a process of continual dialogue with our CCG, who have oversight of the SI process and accountability for that part of the quality schedule in our contract. We occasionally review and update or amend actions accordingly. I'd be really happy, and conscious of the time that it would take to go into this in more detail, really happy to go through that.
No, fine, thank you. Yes, I'll catch up with you. Thank you.
And finally, Simon.
Thanks, Alan. Just to return to a couple of points that David made, I think. So the first thing is that, in actual fact, in Q4, so January through March, April, Northamptonshire was the second biggest user of the independent sector in the country. Of course, that had everything to do with the fact that I was doing my national job then. I'm jesting, just so everybody knows, it was due to the good efforts of colleagues locally. One of the reasons why we were able to do that, David, is because we had a command and control type contract that essentially allowed us pretty much unfettered access into the IS. At April, we went back to cost and volume based approaches to the independent sector. So essentially, they could choose the work that they did, whereas before in Q4, we could choose the work that they did. I just want to call out, I think one of the important policy debates that will need to happen before winter is whether we go back to some form of national block contract, because it's certainly provided an important safety valve for the NHS throughout winter, and the prognostications for our winter this year, based on what Eileen said, are at least as difficult as the one that we went through this time last year, and probably more so. I think the other point I'd make, I'm going to flip that on its head and say, come back to the theatre efficiency point. The other question that we in the NHS have to ask ourselves is, are we making the best use of the capacity that we've got? Because we might regard it as a marker of success that we're spending a lot of money in the independent sector and making use of it, or we might regard it as a challenge for us to improve. Both arguments are possible. So one of the things that I want to do as we shine a light on that data in September is to say, where can we do better? How can we do better? And what would it take for us to do better? So let me just give you one hypothetical to conclude that point. We spend a very large amount of money in Northamptonshire in the independent sector, 35 million at least a year. To do a riff off what Alan says, imagine if we had sufficient capacity so that we could use our theatres profitably and efficiently and maximise that throughput. Imagine what that might look for us. And you know, I think one of the reasons why we've ended up, frankly, spending so much money in the independent sector is a product of what Eileen's talked about, unrelenting and unremitting pressures at the front door. And sooner or later, as a system, we have to stand back and take a far more strategic look at this. Otherwise, we will always end up fighting fires and never end up thinking where we want to be over the longer term. But two things for you to think about. One is that policy-based point. And then the other, as we come back down around the boards in September and through the committees before then, what are our own data telling us about how well we use our theatres?
Okay, thank you all for that. Eileen, there's still a little bit to go on this, isn't there?
Yes, there is. Would you like me to go straight onto the activity report? So this follows on nicely actually from what Simon was just.
Sorry. You still have a finance director bit to go.
I beg your pardon, John. I'm so sorry. I apologise unreservedly. I forgot you were in Russia. Fire away.
That is not a problem, Eileen. I won't take it personally. So given the conversations that have all been had around our pressures and activity challenges, unsurprisingly, the finances absolutely manifest that. So to date, we are in line with plan. That's a surplus of £1 million. For people's benefit, we are planning across the first half of this year to deliver a break-even position. So we're expecting a small deficit in the second quarter, but we are in line with plan at a surplus of 1 million in the first quarter. There are really two stories to that. One is our performance and success in recovering elective activity. So there is a national regime in place for the first half of this year that remunerates performance above 1920 levels. We have been successful in securing some of that money, and you'll see in the finance report that we have secured or anticipate securing about 3.9 million, which is £1.5 million more than we were expecting in the plan. And you'll see in the activity charts that step up in those planned care numbers that support that number. The goalposts on that have moved. We were notified as an organisation earlier on this month that the criteria required to access those funds have become more stringent, and we need to work through as an organisation our ability to meet that. The challenge has been increased really quite significantly, and therefore that's going to give us a challenge on recovering the income that we had assumed would happen in Q2, a number of about 1.4 million. But clearly in terms of our recovery, that's a great news story for our patients and being able to put that capacity in place. On the urgent care side, we have a number of challenges, as you've heard from colleagues, both in terms of having to put in further capacity that has a cost to support the what seems an unrelenting increase in activity at the front door. You'll see in the finance report, high level, that overperformance in income, but a significant increase in spend versus plan, about 3 million in total. A proportion of that is that additional capacity we've put in to support elective care, but about 1 million of that relates to the additional capacity, specifically medical, that we've put on into urgent care. And then the balance, broadly, the increase in additional temporary staffing that we brought in again to shore up that capacity on the urgent care side. So we do have some challenges. We absolutely have the challenges again on pay around self-isolation, the pandemic, and sickness, again, all of which has manifested itself in our performance in pay. We've colleagues have discussed the work that's ongoing specifically around theatres and temporary staffing, and changes that we endeavour to make to improve those areas that will in effect improve our financial performance. But we are working through those and working through those challenges, as I said, in the coming weeks. In the wider sense of finance capital, we are in line with plan, with capital spend of £5.5 million. So no slippage to report at this point. Happy to take questions.
Okay, thank you. I think that is the end of that section. Have we got anything on that in particular? Okay, a couple of points, if I might. The first one is relates to the ERF, the Elective Recovery Fund. The board made some decisions at the end of May, which were predicated on the fact that the balance of activity, what our patients needed and what our staff needed and what the money demanded of us would be a balance, and we would aim for the higher level of activity and the funding of the Elective Recovery Fund. Now, clearly, if that money is not forthcoming, we have, if you like, misunderstood the question. So equally, that money is for second quarter. So if we delay or if we defer what we decide to do about it until our September board meeting, that is at the end of the second quarter. So the event is over, if you like. So I think the board ought to formally say at this point that whilst we recognise that the decision we made in May has been overtaken by the decision by NHS England to alter the rules for that recovery fund, that decision is still under some debate and some reaction from particularly acute trusts. But we probably need to stick with the decision we made in May, that we still aim to achieve the new target, of which I think is 95% instead of 85%, which is more than our original plan allowed us to do, because the effect of deciding otherwise would be too dramatic on our patient waiting lists. But we have to recognise that we can't happily continue into half two spending £1.5 million or thereabouts that we haven't got. Have you got any comment on that one, John, before I come on to my second?
Yeah, no, I have, Alan, thanks. So absolutely acknowledge the conversation about H2. I think that's a very pertinent conversation we need to work through. In terms of quarter two, so the second half of this first half of the year, we have been told by oversight colleagues at NHSEI that our reporting on this will be an acceptable variance to plan. So where we aren't able to receive or account for the income that we would have expected to had the previous set of rules been in place, that will be considered to be an accepted variance to plan. So I think that supports the tone of the comment you've just made, which is we absolutely need to understand what this means for us leaving this first half of the year. But in terms of the remainder of this half of the year, it is expected and it's known that will be a variation in our financial performance. What we need to ensure that we do, of course, is that understand that the capacity that we have put in place is working to the levels that we had planned it to. But from a pure financial reporting point of view, we have clarity and it's an accepted variance to plan.
Okay, and that means by September we should have a clear view about whether we can hit the 95% by the September board meetings as we go into part 2. Simon, I'm sure, is going to tell me I'm right.
I would never tell you were wrong, particularly not in public, Alan. What I was going to say is, look, one of the interesting things that we're talking about, obviously, in terms of half 2, is a system plan around the money. So in the good old days, this would have landed fair and square on the acute trust to solve this problem on their own. And I am already, as is John, with CFO colleagues in discussion about a different type of dialogue, which is how do we handle this as a system? Because if our success is to be measured as a system, then the challenges that we receive have to be measured at a system level too. So I think for those of you who are involved in the System Finance Committee, in the HCP board conversations, this will be an important conversation to flush through. Because as you say, Alan, the impact of us retracting some of the capacity that we've put in would be dramatic. And our success needs to be measured in slightly longer time horizons than a quarter. So I just would note that this is a really important moment for the debate. This is a really important challenge, and you've raised it very correctly. It's also an important test for how we respond as a system, rather than simply responding as an institution or 2 institutions.
Good. I think everybody's going to be happy with that, rather than any alternative retraction of activity. Good. My second point is, over the last few months, we've moved much more to committees in common between the 2 trusts, and listening to the committee chairs, they intend to do more of that in virtually every case, apart from audit. And looking at the IGR, I think now is the time to say to the group looking at the governance arrangements, which is primarily, which is led by John and Rachel, but have others on it as well. They're the exec and the non-exec lead, but there are others. I think it's time to set you a challenge, governance people, that by the end of September, we ought to have a matching IGR between the 2 trusts of Kettering and Northampton. Now, I don't wish to be too demanding about this in the sense of which one wins, but Kettering one is a national exemplar on how this ought to work. So perhaps we could suggest and request the system. And I appreciate Andy, digital will have a role in this. I appreciate all the other bits will have a role in this. But if we can move to September to having an IGR, which is an exact mirror of each other, and the way we report it, led by exec directors and chairs, one for each committee, as opposed to one for each directorate, I think we might make some significant progress in clarifying and streamlining our governance arrangements. Simon.
Yeah, I think fair challenge, Alan, and one that we should now accept. I've already indicated that we will be bringing forward theatre efficiency data, and clearly one of the tests of that will be looking across our suite of theatres in Kettering and Northampton and seeing, are there differences, are there variations? So the data needs to be comparable. I think we should also take the opportunity to look again at some of our core indicators and maybe simplify those down a little. There are many indicators that one can choose. Not all of them have the same value or salience. And so I think this would be an apposite time for us to say, although we need to have the detail, the key thing for the board is to know the difference between the price and the value. And we should perhaps also pick that up in this conversation. So I think it's a fair challenge.
Thank you very much. Andy, you're going to tell me it's possible as well.
Thanks, Alan. Yeah, well, just to confirm, a piece of work was kicked off earlier on this month to look at the metrics across both organisations. Many of us on this call will recall a piece of work that was done about a year ago looking at the metrics across both, 78 metrics on NGH and 54-ish on KGH, and only 8 which were exactly the same. So I just would flag that this is not an insignificant piece of work as we try to square those two things. But yeah, can confirm this is certainly on the cards that people are working on.
Good. Well, there you go. A new challenge for the September board meetings, and going forward from that to get it even tighter and shorter and better. Thank you very much. Nobody picking up on anything there? No. Activity, Aileen.
Thank you, Chair. So in the being short and tight, this is pertinent only because of the conversation we've just had. So this is an update on where we are up to on our H1, our half one reset plans. I'll take it as read, but the main principle being that we are overperforming actually, which could point towards a good thing with the new with the amended target now, but it's just to say that we have gone according to plan and over it. So things are good, but clearly, as the discussion we've just had, the decisions have been made around how we continue, how we fund it to continue, and how we make best use of the resources we've got available before we spend more. So I'll take that as read and take any questions and answer them if I can.
Yeah, I think we've kind of covered it in the IGR stuff and in the comments that came after that. And yeah, I presume that's an old hand. I'm not getting any comments now because it kind of automatically the activity report kind of automatically falls out of all the comments you've made up to now about the IGR. Okay, because there's a little bit of a timing misunderstanding between the people joining us for reverse mentoring, I'm going to go to Karen now. Karen, you shouldn't be surprised, to do item 12 for me, and then we'll have the break. Karen.
Yeah, thank you, Chair. No, I'm not surprised. That's fine. So the paper here sets out our ICS design principles, as Simon referred to at the beginning in his introduction. So really what we've got here, I wanted to just draw your attention to, is we've got the high-level ICS design building blocks and the key blueprint of our ICS design. This really is pretty much now agreed across it's been co-produced by all partners. It's been agreed by all our organisations. This is what our ICS design will look like. So clearly there's a significant amount of work now to be undertaken in developing the detail underneath each of these building blocks and each of these elements. And that's the work that we're now embarking on, and we'll all be, all partners will be heavily involved in that, and many colleagues around this table will be, or in virtual room, will also be involved in those discussions. What I wanted to draw your attention to is just a couple of the key things, the key points, just to pull some of those out. So in terms of what our agreement is, in terms of around our ICS will be designed around our collaboratives. So we will have 4 collaboratives, and those are around mental health, elective, ICANN, and children and young people. And we've discussed those at many occasions, and those are well established as the key priority areas. We will develop our ICS around 2 places. There'll be a single ICS, but there'll be 2 places, and those places are around in sort of coterminous with the 2 local authorities. And more detail is to be worked up around how things will work at place, what will be worked up at neighbourhood. All of that is going to be worked through in the coming months as we move towards April next year. And then the other thing that needs there'll be more work on is around the ICS body, exactly who the membership of that will be, and also the ICS partnership and the remit and frequency of the ICS partnership. So we know there will be a single ICS body and one ICS partnership, but the detail of those are to be worked through. So on page 3 are the endorsement statements. All boards, not only ourselves, but across the partnership, are being asked to sign up to these throughout this month. And so I won't go into the detail of them because they're here and I'll take them as read. But really what I'm just asking for the board is to approve and endorse those statements, recognising the detail is going to be worked through in the coming months. I'll stop there, pause there. I don't know if Simon or any other colleagues want to add anything, or are there any questions?
I kind of expect Simon to want to say something at this point.
Thanks, Alan. Yes, I mean, so thanks firstly for the presentation. That's very helpful, Karen. So I think we've got 4 domains where you're specifically asked to offer any comments or approval. So they're contained in the page that Karen's referred to. So collaboratives, just to say, we will be leading the development of the collaborative work, and I would expect that Angela and I will be leading the development of the collaborative programme as a whole. Place and wellbeing, probably one of the most difficult and areas where there is further work to do to work out what does place really mean. People talk a lot about place, but it's difficult to make that meaningful. And one of the tasks I think we need to do is to be able to make that meaningful to patients. And that point also applies to neighbourhood too. My last point, I suppose, would be I've been talking a little bit in all the comments I've made this morning about systems. So probably one of the most fundamental changes that we're making is moving towards a governance model where we're holding ourselves collectively to account. So in the old days, well, the days that we are leaving, I suppose, they're not yet quite old, commissioners would hold providers to account. There would be a contract. And the relationships that we've enjoyed or endured over the last 15 years across the NHS have been, to a greater or lesser extent, marked by confrontation or competition, depending on how you view it. So probably one of the most significant design features that we've got to get right is in that last box. How do we really pull off a system where we collectively are in this together, roped together, where my success is your success? And that, I think, is probably going to be the hardest yards in terms of the work that we're now about to embark upon. And it's going to involve us all. So we're designing a system where execs will lead on pieces of work, but clearly it will shape the way that boards work. So non-execs will be invited to take part in some of that governance work, because that's particularly key. Design that well, and we've got the foundation of a system. And that's Naomi's happy task, really, and we are really fortunate. So I'll add my welcome to Alan's in terms of her appointment. I think we're lucky to have Naomi to help us through that stage of development. So I'd invite any comments from or observations on those 4 areas of work. And just to say also that we're also going to be heavily involved in some of the enabling work. 2 in particular I'll call out here. The first is digital, because just as we've been talking about a digital journey in our hospitals, that only makes sense if we do it across the system. And Andy is the system digital lead. Good luck with that, Andy. That's going to be quite an important part of our conversations going forward. And then lastly, as we've been talking about, people, we need to increasingly see them as a resource for Northamptonshire as well as for an institution. And Mark's work, taking forward the work of the local people board, will be really key in that. Thanks, Alan.
Okay, thank you much. If this has been through the group involving non-exec directors from both trusts extensively, and there's 5 or 6 non-execs been involved in that across the piece. Are there any, and we will of course be talking about this in the afternoon as well, as we just go through 1 or 2 of the detailed parts of this. Matt.
Thank you, Chair. Just looking at point 5 of what we are being asked to endorse as boards, and not immediately clear, and it's probably my understanding of why we recognise that there are going to be 2 places, but why we would have 2 health and wellbeing strategies in one county.
I'll take that one. The challenge will be one of looking up and looking down at the same time, Matt. So absolutely, we need to have one set of priorities across the county, but we need to, and that's the thing that will bind us together at the top of the new pyramid, the partnership board, the ICS statutory body. And we need to take a longer term view around health. So delivering an effective model, as you know very well, around population health management will be key. I was also indicating, I think in my comments, that we need to be able to point locally. And our 2 new unitary authorities are clear. They want to be able to deliver on their aspirations for how they meet the needs of local people. And I'm articulating, not resolving, one of the key design challenges in the work that we have going forward to make that work effectively, so that we don't end up with an imbalance where either one or the other dominates the conversation.
Okay, thank you, everybody. That's one particular aspect we will be talking about in the afternoon, I'm sure, and we can try and resolve that difficult balancing act there. I don't see any other hands up. That may be because it's now coffee time. So you can have the break that's planned now back at 11 o'clock, please. 11 o'clock, please. Thank you. Okay, 1 minute, guys. Okay, it's 11 o'clock. We should all be back. We're moving on to, if I haven't lost my agenda, we're moving on to item 11, which is the OD and inclusion EDI progress presentation and EDI strategy, which is a whole load to do with reverse mentoring and so on, equality, discrimination and inclusivity, which is a lot of words. Mark, this is your show. For everybody else's benefit, we have about a half hour of presentations and 15 minutes for conversation, discussion and questions at the end. Mark, over to you.
Thank you, Alan. Thank you. So yes, I'm really pleased to be sharing this item, including our future direction around ED&I with the board. Having, I think it was almost a year ago to the day, in July 2020, when we last discussed this item and what we said we would do. And so it's really pleasing to be able to come back now today and demonstrate what we are doing or what we have done. And I'd like to thank and welcome colleagues who've contributed towards that. And there are a number of people that are joining me today to conduct this presentation. Firstly, we have Tracy Robson, who Eileen referred to earlier as our soon-to-be Director of HR and OD in NGH, which is fantastic. We've got Liana Luxon, our Reach Network Chair, who will present in relation to the Reach position and where we've come to in that particular network. And then we've got Andy, who we all know, who will talk to us about what we said we would do as a board, which is really important. We also have a number of colleagues joining us from our reverse mentoring program, and you're also very welcome. We have Fatima and Sam, who we had earlier on in the meeting this morning. We have Andre, Ashok, Bola, and Uche, who have also been able to join us, which is fantastic. So hopefully everybody gets an opportunity to talk through the course of this presentation. And essentially our presentation has four main aims as we go through this morning. The first is to provide an update on the progress more broadly in equality, diversity and inclusion across Northampton and sharing some of the work that we've done in the trust and also as part of the group. To review, and I say Tracy will take us through that, to review our Reach network, what we said we would do, what have we done, what do we plan to do. Liana will take us through that part of the presentation. Then Andy's going to take us through a self-lens, if you like, as a board, what we said as a board we would do and what we are being asked as a board to commit to for the next 12 months. And inclusive in that is the reverse mentoring program, which again has been mentioned in dispatches this morning, whereby we have a short video starring some of the stars on our screen today. It's starring Andre and Bola, and also Anima, who's Alan's reverse mentor from KGH, just a short video around what reverse mentoring has meant to colleagues. And then of course we can have some discussion in and around that. And then I will take us through to the ED&I strategy. So again, what are we going to do moving forward? So this is great progress to date, but what is the future direction of us? And that's the group ED&I strategy. So for both ourselves in Northampton and indeed in Kettering, and this strategy will be presented there too tomorrow. It has been the subject of debate and discussion over the last few months, including at the Joint People Committee in June and again on Monday. So hopefully that, as Alan said, will take us to 30 minutes. We will then have plenty of time for debate, discussion, comment, and we'd really like to hear from colleagues, many on the call who have undertaken reverse mentoring and what it has meant to them and the impact that it's having on them, and things that we could look forward to and conduct in the future. But without any further ado, it's my plan to hand over to Tracy now to take us through the first section of the presentation as described. So over to you, Tracy.
Thank you very much, Mark. Good morning, everybody, and I'm delighted to be able to take you through the progress of work in this area, and I hope that you agree that we are starting to make some progress. So I'll start with a few statistics which most of you will be familiar with, but just as a reminder. So we know that staff surveys are really key insight piece of intel for us, and obviously all of the EDI work ladders up to our overall ambition to be in the top 20% nationally. So it's a really important area of work for us. So we know that the ambition here is to continue to improve those results, and to raise our score and to be higher than we are and get closer to the national average and even higher. Next slide, please. So again, a reminder on our, where we are in terms of breakdown by gender and breakdown by sexual orientation. And the piece for me in the grey box there on the right, around where we've got 16% who really are undecided or might not identify with a particular listed area of sexual orientation, might have ticked other options, is all the time trying to help people identify themselves, because the more information we have, the more insight we have from people about how they identify, we of course can then put in the right support mechanisms and the right information and education. Next slide, please. Here is the breakdown by disability and breakdown by ethnicity. And again, just calling out those grey boxes where really we have got not declared, which is people's right, of course, or other. With reference to ethnicity, we are doing some work to build the trust and encourage people. It either, is what we're asking not getting to the right information, or, why perhaps people aren't. Obviously, we have to be careful with this area because it's private information and we need to respect that. But if there is something we can do to help people inform us in that, that would be very useful information. Next slide, please. So what are we doing? So one of the things we've done is set up a library of diversity and inclusivity information. We call it the Lived Experience Library. This is a best practice idea that has come from other trusts who have this in place already. It's a reference area for people with protected characteristics or managers of people who can go there for all sorts of information. There are podcasts, articles, recordings, and we're continually building this and continually signposting people to this. We're getting good feedback about it. At the moment to date, we've had around 150 visits, but we're doing more promotion of this. And we'll continually, as I say, signpost it as a reference point to help support and continue to educate ourselves and our managers so they can better support their people. Next slide, please. We have in place a number of shared decision-making councils. Some of these are aligned to specific wards, like the example given there. Holcott Ward have a council, and some which are based against themes such as sustainability. This is so that we've got a structured mechanic where people can have a voice. They're set up so our staff can bring their ideas, thoughts, their voice to the table and feel empowered to contribute towards certain key decisions. One of the things that we've also set up is during the designation journeys, it says there for our international nurses to set up a specific shared decision-making council for them. And delighted to say that that council has recently appointed a new chair, Maureen, and who is going to be leading that for us. And this is a call out to Sharon and the team, because there's a lot of commitment and support to this, and it's working very, very well, and we're getting some good feedback. Next slide, please. So in terms of nursing and midwifery, a couple of call outs that we wanted to highlight here is programme for Director of Nursing and Fellows. This offers mentoring and protected time out of practice for people who take part in this programme. Again, shout out to Sharon, who I know mentors this programme, puts time and commitment to it, and we're seeing some really good feedback. We have some interviews set up for September, when we will be appointing the fellow to be included in that programme. So that's really great progress. And on the NHSE BAME Aspirant Nursing and Midwifery programme, two places were available regionally, and again delighted to say that Sam Sabanda was awarded a place on that and has already started to give some good feedback about her experience through that. It's quite a rigorous process in terms of application, so it's really great news for NGH that we've got somebody appointed to that programme, and Sam will continue to give us feedback as she goes through that. Next slide, please. Career cafes. So these are run, and they've been up and running since May 2020. We have these available to colleagues who are developing their nursing. So this is providing advice and direction around all aspects of career development, getting you ready for interviews, helping you with CV skills and presentation skills. To date, 27 colleagues were offered coaching and development through these cafes, and 44% of those were our Reach colleagues. And they have set themselves a goal, and they're working towards attaining a 50% ratio of attendees from culturally diverse backgrounds. So really great progress in that area. And professional nurse advocates, NHSE promoted this for our international nurses to apply to, and colleagues have been supported and mentored to complete applications for that particular programme. And while we're on nursing, those of you who are on Twitter might have seen and heard the great news that one of our people, Fatima Gouch, I hope I'm pronouncing your surname correctly, Fatima, great news to see that in the Race Matters Award run by the Royal College of Midwives, she's a nominee for that award. So that's fantastic news for us. So just to call out whilst we're in the nursing space. Next slide, please. So an update wouldn't be an update without mentioning COVID. And of course, one of the things that the SOS team, they've done tremendous amounts of support for all staff. And we know that that was recognised through the Health and Wellbeing Employer Award. But there were specific things put in place for our colleagues of BAME background, because there seemed to be additional pressure on the Reach colleagues who may have had higher vulnerabilities. So it's very important to set up a support group that was developed to address their specific concerns, and that's been through education support and generally raise awareness. And again, that has been something that we've had particularly good feedback about, and we continue to support. Next slide, please. We're building stronger bridges with across the group, HR to HR, EDI team to EDI team, about what we can do in terms of training and education. So leveraging one of the programs that Carol Renner and team were leading on in KGH, and we ran our first cohort under building cultural bridges back in June 2021, and we've had really great feedback from that. I personally attended that, and it was a 2 half-day program, and it was specifically talking about culture and race, and really great conversation and education through that. And I really recommend that to people to attend, even if you think like I that I've been in HR for a number of years. I have some experience in the cultural education part, but this was very helpful in unlocking further conversation, further education for me personally, sitting in a room with people who had very interesting stories to share with us. And it's a really great piece of education work, and we're going to be rolling that out and continuing that. Of course, we know that in the background, Dr. Tayosi has also been doing some work around unconscious bias, and they've been doing the same in KGH. So we're really starting to have really meaningful conversation and getting some really robust education to unlock some of our current thinking and understanding. And you're always learning in this particular area, I'm sure we'd all agree. Next slide. So I think it's fair to say, probably up until the beginning of this year, that, you know, we've got the REACH team who've done amazing work, and Liana will share soon all of the progress that they've made. But some of the remaining staff networks didn't seem to have the same structure, or they weren't quite in the same place. So we did put some attention around that in the earlier part of this year, and we thought about with the networks what we could do to relaunch them, what we could do to rebrand them so people understood what they stood for, and we made sure that we created the very necessary facilities time for the right people in the chairs and co-chairs to attend these particular networks and make sure that we actually were progressing in these areas. We go to the next slide. Thank you. As you can see, if you haven't seen these already, this is the work in progress. So Pride is the rebrand for our LGBTQ+ network, Dawn is our disability network, and Voice is our NGH Women in Medicine network. So we're still working through, we've got co-chairs elected in some of them, we've got agreed terms of reference in place, and we're working very closely in HR to make sure that we get the right plans around them to facilitate the agendas that they want to deliver. Next slide, please. So if you aren't aware, here's where we can show you who are the sponsors of each of the networks. It's great to see that we've got a balance of our NEDs as well as our executives in support of these. And I know, for example, one of the things to call out that is very notable, I think, is with regard to the Pride Network, Andre Gore, who works with me, doing some wonderful work in a series of interviews with some of the executives, and did a very superbly authentic interview with Jo Forkus, and relating it back to her support of the Pride Network. And as a result of that, we've had about 53 new members join, come forward and get some badges to say, I'm a person you can talk to, and joining in. So it just goes to show, I think, that, you know, it doesn't always take money or a lot of effort to drive, you know, an impact. So it's very good to see. So keep up the good work, Andre, because that's really making a difference. Next slide, please. So what are we going to be doing in the next 12 months? Well, we're certainly really now feel like we've got a plan in the next few months. As I said at the beginning, I really feel like we've gathered a lot of momentum in this area. We're going to approve and continue to deliver the EDI strategy for the group, working closer with our team in KGH, continue to support the EDI networks and grow membership by helping to build confidence of safe spaces that we've started to create for all the networks. We are going to continue the education, and that will be in the form of things like the library, but also training and networking programs. We're going to launch a United Allies program, continue developing role model stories, because as we know, it's stories that have an impact and change the conversation and culture, and to embed cultural change and understanding through the programs that we define. We have put some shared targets together. They're there on the left in terms of what's the ambition, what is it we want to achieve. They're shared with Kettering. So, you know, there's a lot of momentum now in place. We believe we can deliver against this plan. We have clarity, we know what we want to achieve, and we continue to you know, really look forward to your support and encouragement in this area. So I'm now going to hand to Liana Luxton, who is our chair for the REACH group, to give her update. Thank you.
Thank you, Tracy. So Good morning, and thank you for having me talk about our wonderful Reach network. And I'm very proud of all that we've achieved this past year with Reach. Myself and the co-chairs with our recently established protected time can now do even more against this agenda moving forward. So I just wanted to give you a brief update on our achievements to date. We still do our bi-monthly meeting with Reach online, and in the intermediate months we have established a newsletter which is published and circulated trust-wide, and this newsletter is updated with information and news about everything that we're doing. We've raised our network membership from 30 colleagues to over 300 and growing, and that's through, again, I'm going to do a shout out to Andre with his work around our social media and our newsletter, and really trying to bring people in, but we're still working on hard to reach staff groups and those who are not free to attend those meetings. And Andy Callow has really supported us with letters to managers around the importance of allowing staff to attend these meetings. We have had many different Reach representatives on interview panels for all of our senior appointments, and as Tracy said, we're working with our Reach staff group who want to be trained, and one of our members at NGH has attended our inclusive interview training, and that will be rolled out across NGH. Dr. Tosi has been delivering our unconscious bias training, and we're aiming to train over 100 colleagues in 2021, and we're working to develop our other staff reps. We obviously have our international nurses rep, our EU Brexit group rep in Beata, and I've been talking with our AHP head of therapies to develop a therapy rep also. I'm around to support our participants on the Reach Reverse Mentoring Programme, and we've also been establishing additional training to have more Reach Freedom to Speak Up values ambassadors, and we've done lots of training on that and more coming up in the future. We've worked really hard to develop our relationships with our HR colleagues and our OD colleagues, and we're really proud of those relationships and how they've really pushed forward this agenda, and also our close working relationships with KGH, and offering that joint training and sharing work has been something that I've been working tirelessly on to build across the group, and I can't wait to show that over the next year. Next slide, please. We also have been trialling with our Reach student midwives the use of the Liberate app by NHS England. And as we all know, with COVID and the disproportionate effect of everything that's happening in the world, health and well-being for our Reach staff is of paramount importance to myself and also the co-chairs. So they are trialling this app, which was developed by those of ethnic minorities for those with ethnic minorities, with bespoke interventions on anxiety and relieving stress and promoting rest. And we really want to see how easy that is to use and whether it's successful, and hopefully roll it out to other staff moving forward. Next slide, please. So with all that said, there obviously is still lots to do, and over the next 12 months we have a really good and robust plan of things that we would like to achieve. We're still working, as I presented at last year's board, on our 6 work streams, and they include around developing increased engagement, especially with our hard to reach staff members, and developing our aspirational leaders series even more. Our work stream 2 is around information and intervention, so use of data to drive forward what we're doing with our interventions across the hospital. Developing bespoke NGH Reach group developments, and that would be the development of our own training at NGH and potentially sharing that across the group. Our 4th work stream is around talent development and strategy, and that houses reverse mentoring alongside other initiatives. The development of more staff reps to follow in the amazing lead of Dr. Toyosi Adeneji, and developing our events and campaigns. And we're really looking forward to the event that we have in relation to Black History Month, which is going to be on the 15th of October. We have a dream of who we want to speak and how we want it to go, and that is coming into fruition. So we're really excited about that. And all of those work streams, we are going to be working closely with our EDI lead to develop our Reach Network action plan even further, so that feeds into our group strategy, so that we're all working together cohesively across the group. We're also going to be developing more freedom to speak up values ambassadors across the trust. It's really important that people have safe spaces to speak and have supporters and people that will challenge. We're hoping to recruit more diverse SOS colleagues and support services across the trust, and especially those Reach SOS colleagues. I'm working closely with Anne-Marie Dunkley around developing health and wellbeing surveys and getting more information from our Reach colleagues about what will help them specifically around their health and wellbeing. We have access funding and we will have funding for the delivery of events and activities, which we're excited about. And one of the really important things is having more listening events to understand the bullying and harassment that occurs within the trust. We know that, and it's freely out there. So we have secured drop-in sessions with Reach co-chairs to allow people to have safe spaces to speak to us, and we'll be developing more listening events moving forward. And last but not least, we will be using our data that Tracy has kindly shared, but also from our conversations with staff and their lived experience to really hone in on bespoke areas of training for departments where there's hotspots of bullying and harassment in the organisation. There are many other things that we have on our list, but those are the highlights. So I hope that gives you a brief summary of what we're delivering over the next few months. I'd like to hand over to Andy to talk about the EDI board actions for Reach and your accomplishments and deliverables moving forward. Thank you.
Thanks, Liana, and what a great summary. So colleagues, I'm not going to go into massive detail in this stuff. You've heard from other people around all the achievements, and I think you can look there to look back on the past 12 months with some satisfaction. But I want to focus this conversation really on what we're going to do in the future. So you'll note an action there, and I'll pick that up in a second. And what I'd like to focus on is about the reverse mentoring program. So if you could just go on to the next slide, please. So we've talked about it a little bit this morning. Reverse mentoring is in place. We've got 7 pairings across the organisation. And you've heard Simon say about how it's personally impacted him. I can say it's personally impacted me around having that access to somebody from a completely different cultural background and opening my eyes to different experiences and how we need to make different decisions and different approaches within the organisation. So it's my pleasure to introduce the video where just a couple of the folk who are involved in it talk about their experience. Thank you, Kieran.
Hello everyone, I'm Anima. I'm a nurse from Emergency Department. Also, I'm the reverse mentor of Alan Burns.
Hi everyone, my name's Andre and I'm HR Project Officer. I'm also co-chair of our Reach Network and also our newly launched Pride Network.
I'm Bola Bola, Interim Hospital Director of Finance, and I've been on the reverse mentoring program with Andre.
The biggest thing I've learned, the biggest thing I've taken from reverse mentoring has been, it's really helped me not to be fearful when speaking with senior leaders about important issues, and it's given me the confidence to hold them to account when necessary in a way that I wouldn't have done before. It's also been really impactful and helped me build relationships in the trust with people, particularly Bola, who I would never have met normally, and be able to really speak candidly with her, and that's been really amazing.
I found the program really useful to get to understand other people's lived experiences. So Andrea and I shared about, the experience, some experience that he had, and that was quite revealing, really, of the situation. And we also then said, okay, right, let's look inwards, let's look further and we spoke to someone else, who had recently relocated into the UK and taken up their spouse actually, had taken up a role here, but their experience was nothing but it wasn't nothing like what we would like to build as an organization. And so that was not a very nice experience at all. However, what was also really good to see was how they had found Andre as a body, and how he had helped them, to settle in, find their feet. And we set up a meeting and set up follow-up meetings, and we've got some further actions coming up to explore that further. I suppose the biggest challenge then for me would be there's so many other people like the person we met, and it's about how do we as an organization empower people to call out bad behavior and to support them when they do that. So we will be doing some more work on that.
We came to the following conclusions. The trust needs to focus more on staff retention and staff satisfaction. BAME staff needs additional leadership training for their career growth. Developmental roles such as link roles from each department should be communicated appropriately. If there is more than one candidate for one link role, there should be a criteria for selection.
One thing that I think I would like from the board moving forward would be continuing with reverse mentoring, but also committing to, I don't know, 1 or 2 of our equality, diversity and inclusion trainings that I think would be really interesting for the board to partake in, even if you're not involved in reverse mentoring, so that we can really increase your learning, your experiences, and really broaden kind of your horizons in terms of inclusion, and see how we can help and support our colleagues in the trust.
Thank you. So a really great video and some calls to action there. You'll see there's the 12-month action plan that we've got here. And again, I'm not going to go into those into detail, but I will ask you to remember one of the things that Mark said back when we talked about this 12 months ago was around the 7 A's of authentic allyship. And that was the model from Yvonne Coghill. And the final A being about taking accountable action. And many of you know that the White Fragility book has been very influential in my learning this year. And I'd just like to give a quote that says, and it's talking about society and our organizational structures. The default of the current system is the reproduction of racial inequality, and it does so with efficiency. To continue reproducing racial inequality, the system only needs white people to be really nice and carry on and be friendly across race. But niceness is not courageousness. Niceness will not get racism on the table and will not keep it on the table when everyone wants it off. So my challenge to us as a board is to say, what will we commit to this year to keep in that uncomfortable zone and keep racism on the table? Thank you. I'll hand over to Mark.
Thank you very much, Andy, and Tracy and Liana beforehand. That's been fantastic at this presentation as to where we are and what we aim to achieve in the next 12 months. If I could take the next slide, please, Kieran. One of the things that we aim to continue to achieve, as Tracy and everybody has referenced, is our equality, diversity and inclusion strategy. And it's almost one of these things that when you write it down and you say this is what we're going to do, that's how we can hold ourselves to account. So in terms of using one of our new trust values, how do we hold ourselves to account against what we said we would do, and where are we against that particular plan? And really taking on Andy's last comment is a fantastic comment around courageousness, which is another one of our values that we shouldn't forget. How can we be courageous in this space? It can be, and it is challenging, and that's one of the huge benefits of the reverse mentoring program is to hear people's lived experience and really be challenged about your own thinking, and what you thought was the situation or a situation is absolutely not. And particularly for us as board members, given the positions that we hold, I think people tell us what they think we might want to hear sometimes, as opposed to what we really need to hear. So moving forward with our strategy, I won't take us through the detail of this slide. Colleagues have had this in their packs in terms of how the strategy was brought together, but of course it encompasses and incorporates the EDS 2, the Equality Act, as you imagine, from 2010, and indeed all of our recent group and indeed regional and system priorities that we've set in this particular space. And I think that's really important to say too. Not only are we working significantly across both trusts and therefore as a group, but we're also working very, very closely with our system partners in this particular area of ED&I to make sure that we are taking learning and sharing best practice. I think that's where we absolutely want to be. We want to be the people that people are learning from, but we're just taking advantage of others at this particular moment. If I could take the next slide, please, Kieran. The final slide of this particular presentation before we open this to questions and debate. Our strategy, as seen in the documentation in the board papers today, will focus on 5 goals. The 5 goals that you can see written here. And then there was a case of, okay, that's very good, and these are all great words, but what are we going to do to measure that? And it was in a slide earlier in the presentation today. And I think this was what it was. I don't think it was also raised, obviously, by Fatima and Sam this morning in relation to the Building Cultural Bridges programme. And you can see within our board actions, I think it's really important in one of our board development sessions that we absolutely take the time to undertake that programme too, because that's what we're going to ask a significant number of our staff across the group to undertake, 5% in the first year, and to grow it on from there. So there are a number of measurements that we will continue to bring back to this board, because we think it's very important that we focus on our achievements and indeed areas of stretch or where we need to progress. Liana mentioned earlier, one of the things that Liana challenged us on around was, where do we get the time to do this over and above our very, very, very busy jobs? And that's something that we have been able to do, is to try and is to obtain that funding to make sure people do have protected time to undertake and support in these activities, which ultimately will then improve our staff experience, our colleagues' experience within NGH and indeed KGH, and then we will see the results overall in our national staff survey too, we hope. So that's the presentation from us this morning. I hope everybody found that informative, and it's now to open up to questions, comments and debates. And I know, Alan, obviously it's going to be a tricky one to manage, because I can imagine hands will shoot up like no tomorrow. So over to you, Mr. Chairman, to manage this part of the debate. Thank you very much for the screen sharing as well, Kieran.
Thank you very much, Mark. Thank you very much for everybody who took part in it, particularly those of you I haven't seen for a while, Rihanna, Audrey, and others. Anyway, comments, questions, contributions on that, particularly from anybody who's been in the reverse mentoring programme, but actually wide open to anybody who wants to talk. Karen, then David, then Rachel.
Thank you. That was a fantastic presentation, and I just wanted to add to it really to say that I've got the absolute privilege of being mentored by Fatima, who you met earlier today, and the experience that what I've learned from that. And so from my perspective, it's been a real eye-opener to have those conversations, to listen to the stories and her lived experiences. And it's really made me challenge myself, and she does challenge me on what I can do and what I need to do to ensure that we do really promote the inclusion, diversity, and eliminate discrimination. So I just wanted to comment on what great experience it is and how I shall continue this programme with Fatima. I don't know, Fatima, I don't want to put you on the spot, but oh good, you have got your hand up. I didn't know if you wanted to comment.
Yeah, if you don't mind. Yeah, I definitely echo what Karen just said, and I want to say it was a great opportunity and still a great opportunity to have this open and honest conversation between each other, and as well as building confidence in myself and a lot of empowerment from Karen. And I think is as well, we reflect together, we're learning from each other, but especially we are trying to grow within ourselves, determination to make the change where is needed. So thank you, Karen.
I think thank you.
Thank you. David, then Rachel, then Jill, then Denise.
Yeah, thanks, Alan. Yeah, just a couple of plugs first of all. I think Liana or Andre referred to the subconscious bias training. It's really great. Dr. Toyasi runs it, and I really do recommend that to anyone who hasn't been on that particular course. The second thing is, I listened to one of Andre's his interview with Joe Forkas the other day. I think it's on LinkedIn, Andre, I think I'm right in saying. And I really would recommend everyone to take a look at that. It really is very informative, and quite frankly, it's compelling viewing. You know, and my last point is just an observation. I too am participating in the reverse mentoring program. I have a great mentor in Ashok, who I'm delighted to say is here today, listening to this board meeting. You know, I'm more and more convinced as a result of our conversations and hearing about someone else's lived experiences, that this is a really important part of what the Trust is doing in this space. And, you know, we're not where we want to be in the EDI space. So I also think that this program dovetails particularly well with the other work that's being done. And, you know, Leanna, Trace and others have gone through what we are doing. It really does enforce the importance of that agenda. And I think it demonstrates that we are all involved in making this Trust a great place to work for everyone. Thank you, Alan.
Thanks, David. Rachel.
Probably a question for Mark. I want to just pick up on something that Bola said around support for people who do speak up. How do we go about ensuring that people who do find the courage to speak up get the support they need? And do we track that to ensure there are no long-term negative consequences? It's quite a big thing for someone to actually step forward. So how do we go about that, Mark?
Thank you, Rachel. And we absolutely do look after, sounds totally the wrong way, but we do support colleagues that come forward. Claire's the best one to answer this as our Freedom to Speak Up guardian in terms of colleagues that will come forward to her or via the champions that we have. So Claire, I didn't know if you want to refer to this.
Yeah, anybody that comes forward to me, Rachel, listen to the issues they raise, and clearly depends on what they are. If they are bullying and harassment issues or behavioural issues, which you'll see my report later goes into in a bit more detail, I will get them support with my HR colleagues, and I work very closely with Tracy and make sure that staff are supported and taken, you know, if they want to take things through formally, or if they want any support, any SOS input or any other wellbeing input that people might require as well. I don't know if your question was related to the staff coming from overseas and newly landed rather than freedom to speak up, particularly Rachel, but that, you know, we do anybody that comes to me is completely supported and followed through on.
It wasn't particularly about the staff coming from overseas. Okay. I just know that when people do find that courage to step forward,
yeah,
it's a very nerve-wracking.
It is, and they're always thanked, and you know, because clearly it is a very brave thing to do for some people, and you know, it is the culture is improving in that respect, I would suggest.
Okay, thank you.
Jill, then Denise, then Anne.
Thank you. Yes, to echo what some of my colleagues have already said, it's an absolute privilege to be involved in the reverse mentoring programme. I'm lucky enough to have Sam as my reverse mentor, and so as you've already seen her alongside Fatima, you will know she's an amazing woman. So thank you, Sam. We're early days in our relationship, and I'm sure there's a lot more work to be done. But a good example of where Sam has helped me is that although I've done the unconscious bias training, I struggled to know what I didn't know. So, you know, a bit like the Johari's window, how do you know the bits that you can't see? So Sam helped me to see from her perspective how different it was to be her rather than me. And so a practical example of that is that recently I've been doing some clinical shifts. And at the end of the shift, we have a safety huddle. And I noticed, which I might not have noticed before, or definitely would not have noticed before, that my BAME colleagues were standing in one group as part of the safety huddle, and my other colleagues were standing in another group. So I went to stand with my BAME colleagues, and I've noticed that every subsequent safety huddles, we're merging more and more. So that's a very small step, but it's a practical example of becoming aware of your actions that can make a difference. The second thing I wanted to say was, I was going to say this in the Freedom to Speak Up item, but as we've already touched on it, Sam shared with me that she's talked to people in other trusts, and they have two Freedom to Speak Up guardians. One is a BAME representative. Now, I know you already do this through the Reach group with co-chairs, asking people to drop in and talk to them, but it might be something that we want to consider to formalise or not. But I just thought I'd mention that. Sam might want to say a bit more about that in a minute. And also, I was also going to say that I've started my face-to-face drop-ins recently across maternity and neonatal services rather than virtual ones. And almost to a man and woman, people are not aware of the opportunity for the freedom to speak up. So I think what Claire's going to tell us is that this is going to be part of an induction programme going forward. But I think possibly we need to do a mass communication campaign about where to go, the support you get afterwards, and how useful it is to us as an organisation. So just a couple of comments.
Okay, thank you. Denise, then Sam.
Okay, thanks, Alan. Yeah, I mean, firstly, really great presentation, and congratulations to everybody involved in it. We've obviously been seeing this coming through People Committee, so I know that there's an enormous amount of really hard work that's gone in from all sorts of people, including Malcolm team. So brilliant to see it here at board. I think from my point of view, what was sort of going through my mind, having seen it all culminate today, is that a lot of really good stuff to do. We're all acknowledging that there's more to do. You know, this is an issue that we've got. And I guess I'm kind of thinking about the scale of things. And I appreciate and understand that you've got to start somewhere. But for me, unconscious bias training, that's really useful. That's really helpful. And it does really get people thinking. We're only planning or targeting for 0.5% of our workforce to go through that. I think we need more. And also, and again, I appreciate it's a start, but 5% of staff on the Cultural Bridges programme. And I guess what I was thinking is that this, in terms of some of the really hard things that we're talking about, and the exposure to what is not acceptable, what is acceptable, and calling out bad behaviour, we need to get that right across the board. We need to increase the numbers here. It needs to be made really, really clear from our induction training onwards. This is what we're looking for. This is what we accept and we don't accept. And I think as a NED, you have the beauty of being able to give an opinion, and then you're not the one that's got to try and put it into practice. And I do appreciate the practicalities of that, but I think we should be thinking scale, because this is big for us. And then also, just very briefly, I'm also on the reverse mentoring programme. My mentor Uche is here. I'm delighted to see, and I've learned an enormous amount from it, and it's really helped me to focus not just on differences, but also on communication in general, which has impacted on other things that we're doing. You know, the way that I think about other things that we talk about as a board. So I don't want to put Uche on the spot. She hasn't put her hand up at the moment, but if you did want to say something, then feel free, Uche. Thank you.
Okay, sorry, I lost it there. And then Sam, then Sharon, then Matt.
Yes, thank you. I have participated on the reverse mentoring program, and working with Jill has actually been a fantastic thing for me, because I always say, I think my personality comes across as two different people at different levels. I have always led all my life. However, in my work experience in the NHS, I've worked for the NHS for 15 years, but have never come up, have never gained the courage to come into leadership up to the position where I am now. Yes, I'm a Band 7 in the trust, but did I have a voice prior to reverse mentoring? Maybe not. I was one of those that something happens, you just don't talk about it, because who is listening and who is going to do anything about it? It really does tend to slow people down. And I find it has slowed me down in terms of progression in my career. Reverse mentoring has certainly given me a voice, and has given me courage, and has given me just the confidence to open my mouth and say, yes, I can do this, or to even go onto the aspirant BEM leaders course. I think it's really helped me, and thanks to Jill. I know that you mentioned about the freedom to speak up ambassadors or guardians that are happening in other trusts. Recently, there has been a call for training for, I think it's the co-chairs from the REACH network to become BEM ambassadors in terms of freedom to speak up. Why that is essential, or why I think that is essential, is people will always want to speak to people that they think are listening to them. In my situation, I would probably want to go and speak to someone who I think maybe who's also from a minority background, because I would not have a fear of being maybe chastised, or a fear of being not supported, which is a subject that came earlier, a point that came earlier, that where is the support after people who have spoken out? So I think having those guardians in place will be a very, very key part for our trust. And I think that's a way forward. And thank you very much for reverse mentoring, for finally giving me a voice. Thank you.
Okay, now I don't want to cut this short, and I do recognise all the passion that's around. However, we do have a tricky timetabling issue here. So I'm going to go Anne, Uche, Sharon, Matt, and I think I'm going to give the last word to Liana as chair of the as chair of the BRAIN group. I think we're done at that point, looking at the screen. So Anne, Uche, Sharon, Matt, Liana, please.
Thank you. I'm really encouraged by what I've heard today from all the presenters. And also, I joined my first REACH network meeting as the NED sponsor. And I was so impressed by the drive, energy and commitment of Leanne and the co-chairs and the team. And I really do believe that they will hold us accountable for delivering on this action plan. I think we do have the architecture in place now for us to be able to build a truly diverse and inclusive organisation. But it is down to us, our own individual accountability, to make a difference. And I think Andy mentioned the White Fragility book, and he set up a little pilot with his some members of his IT team, which I was invited to join. And it was a really brilliant conversation, because it really does challenge your own thinking. You think that you're not racist, but actually, I discovered that we probably all are, but we just don't know it. But we definitely, what it taught me was that we really do need to challenge the structures and behaviours that prevent us from moving forward on this agenda. So thanks, everyone.
Okay, thank you. Uche, I think you're probably responding to something Denise said, but over to you, Uche.
Yes, thank you for having me at this meeting. I am Denise's mentor. I'm really enjoying the reverse mentoring program. It's a really great opportunity. And I think it will really start to help break down some of the barriers. One of the things we've been talking about quite a lot in our sessions is communication between the leadership in the hospital and the rest of the staff. And I do feel like there is a lot of work to be done. We're just at the beginning, and the reverse mentoring program is a really great step to move towards breaking down those barriers in communication. I do feel like it's still, even though the channels are open, it can still be tricky to speak up openly. We do have freedom to speak up guardians and ambassadors, but it is still a tricky thing to actually be open and honest, because there is fear at the backlash, and you know what it can mean for your career that you're trying to build and your reputation. So yeah, I think just to bear that in mind, and moving forward, if we can develop more of these types of mentoring programs for other networks, that would be great. I am aware that we've lost our EDI lead, and I'm hoping that we're looking to recruit actively for that position moving forward. So yeah, thank you.
Okay, we'll come back to that last point. Thank you, Uche. Sharon, Matt, and Liana, and then last word to Simon. Sharon.
Thank you. I just wanted to raise a point, or just highlight something that Tracy alluded to in her presentation. She made reference to the BAME aspirant nursing midwifery leaders programme, which was taking place across Midlands. Now, each county was only given 2 places. So we worked with the system and we submitted 4 4 nominations from across Northamptonshire, which were strong. I'm absolutely delighted that of the 2 successful applicants, Sam was one of them. However, that did leave us with a bit of a quandary, because overall in the county, we'd received 25 applicants for taking part in the programme, and 16 of those 25 were from Northampton General Hospital. So there's 2 things that we have done in response to that, because I feel absolutely committed that if people have expressed an interest, then we need to create an offer for them. So of the shortlisted candidates that were not successful, we've organised for them to have some bespoke leadership development training, which is being supported by NHS EI for Midlands. And what I'm doing as well is I'm working with with Northamptonshire Healthcare Partnership, looking at how we can provide a programme for the other 23 applicants that was not successful on the course. So there's going to be a local offer for them. But I think underneath this, there's a strong message that our main staff are looking for leadership development, and we're looking to meet that need. Thank you.
Excellent. Matt.
Thank you, Chair. I'd really like to revisit and emphasise Rachel's point, because I think it's incredibly important from my experience, how we react when people find the courage to approach us and raise an issue that relates to inclusion or otherwise is absolutely pivotal. So when Toyosi first came to see me, and I was fairly early in my journey of understanding of my role and in the inclusion agenda, I asked her, I said, if Northampton General Hospital really has so far to go and really is such a poor experience for our BAME doctors, because that was particularly the staff group that we were discussing, said, why is this the first time? I've been here for over 2 years. Why is this the first time that I'm hearing it? And she was really straight with me. She's always been really straight with me. And sometimes it is hard to hear. It's because people do not feel confident or brave enough or worried about the repercussions. It's absolutely how we react when we hear it, how we welcome it, receive it and respond to it makes all the difference. And because from Toyosi's perspective at least, responded in a positive way and made her a BAME clinical fellow and set about a work programme to support our international medical graduates and BAME doctors more broadly. I've had a steady rush of BAME doctors, consultants, junior doctors come to talk to me about their experiences and enrich my understanding. And a lot of it is really difficult to hear, but if we don't know about it and we do not listen, then we cannot improve it. In a rather drier and more technical answer to Rachel's question, I'm responsible for clinical incidents in the trust, and we are building into our incident management system and processes wherever discrimination under any of the protected characteristics is reported as a feature in the incident, then the process that we are building in, we're doing a little bit of work with our incident reporting system, is that the relevant EDI group, so in this instance BAME, but it could be the Pride, it could be Voice, etc., will be involved in closing down that incident to make sure that we are looking after the people who have been brave in the first place. And final thing I'm going to just have to say is I am so impressed and proud of the progress that Liana has led and made, making us a better hospital for everybody to come and work in. So thank you.
Thank you, Matt. Right, last two, Liana and then Simon.
Thank you. I'll keep it brief. I know that as Reach Chair and for our co-chairs, we've really felt that this agenda has been just on our shoulders for a long time, and coming to this meeting and having the opportunity to speak here and hearing all the progress we're making and how we're moving it forward, it can start to feel that it's on everyone's shoulders and everyone's responsibility. And I think then that will help with the scaling, because it has felt a massive beast in terms of trying to figure out training when only Dr. Tosi is doing it and scaling that up to the whole hospital. So as we spread the load and as we get more people involved, it will address the issue with scaling of things. I definitely agree with the people that have said about speaking up, and I know myself and our former EDI lead spent a lot of our time working with staff members to give them the confidence to be able to speak up. And we have lost staff, many staff members, and I know not all staff members have come to me about their issues to this. So there is a plan, as Sam said, to train all co-chairs in freedom to speak up. There is a plan to have all of our BAME group trained in freedom to speak up. But again, that involves scaling, and that's where the commitment comes from the board to this agenda to help that to happen. In regards to accountability and that being one of our key drivers as a group, having people that, you know, Carol is such an amazing diversity lead at KGH, and she made a really good point. When members go to Building Cultural Bridges training, they are becoming aware. A lot of the things that happen are when people say, I'm not aware that I was being racist, I'm not aware that I was being discriminatory. Once you go on that training, you are aware, and then you become accountable. And actually then you can, as leaders and middle managers, really say, well, you've been on this training, so what are we missing here? So I think as we start scaling that up, it becomes easier to hold people to account. And I would say that I would ask all leaders to really support colleagues to attend REACH meetings and attend training, and challenge when people aren't allowed to go. I get so many emails from people saying, I'm not allowed the clinical responsibilities, my manager won't let me, they don't see the point in these meetings, XYZ. So we really need to allow people to be able to attend, to start to make culture change. So those are the points I had. Thank you.
Thank you, Leanna. Simon.
Thanks, Alan. Just firstly wanted to thank everybody who's contributed to the debate today. Sam, I think you put it best, actually. You said, I didn't used to speak up because I thought I didn't have a voice and nobody would listen. Well, thank you for giving me a voice, I think was what you said. And I think that kind of captures the debate that we've been trying to have today, to give people a voice. And I think my commitment to you in response is to say, it's great that we've had this conversation today, but giving people a voice is something that you need to do every day in every way. And so one of the things I want to say to all of you who've contributed to the debate today, we will strive to do our best to honour the contributions you've made by giving you that voice. So thank you all.
Okay, thank you very much, everybody. Quite a while ago now, when I first met Toyosi and Leanna in my office, which I don't think I have anymore, but when I did have an office, I opened a conversation with them by saying, I absolutely accept we have a problem. And I still remember the look on Toyosi's face when I said that. So I think this is a significant bit of progress, a significant landmark. We have got a lot of other things to do. And I'm taking it as read that you're agreeing I think 8 objectives that were up for the board over the next year. There's no single person has said no to any of those, which was really the ask today. So I'm taking that as read. That is the board challenge for the coming period. Thank you very much to everybody who's joined us for this. You've all been very welcome. You've all been very articulate. You've all been very passionate, and it's very, very good to hear. So thank you very much, everybody. Thank you for your time, and thank you for your commitment. I hope you think we've made progress on this going forward, and I would expect to see most of you again next year. Thank you very much. Right, just let a few people leave. They're just clicking off now. Excellent. So that was a very good session. Thank you very much, Mark. Thank you for everybody else who were sponsoring it and all the other people involved in it. 13, Freedom to Speak Up Annual Report, which is a little bit of a continuation theme to it. Claire, over to you.
Thank you, Chair. I'll take the report as read. The report has been submitted to the People Committee back in May, and you will note that this, in the previous year, we had 42 cases, which was a big decrease on the previous year. However, it is in keeping, if you look at just the pure numbers, on an average for a medium-sized trust of 10 cases per quarter. Last year, obviously, we've got to bear in mind the COVID impact and the inability to meet people face to face. So most of the contacts were done via telephone or by Teams. But we did manage to do some training in year, which I was delighted to do. And we did have some of the REACH colleagues, including Toyosi and Andre, who were both on that call, who have been trained as Freedom Speak Up ambassadors. You will note from the report that 52% of the cases were issues with bullying and harassment, which can be on the wide spectrum of what that covers, from a sort of behavioural to full bullying and harassment, if that makes sense, and everything in between. That is in keeping with the national figures that most trusts have presented for the last year. As it's been stated many times, there are 2 sessions booked in September, which I'm hoping to get filled to the brim for further training for the REACH and other networks colleagues, to make sure that ambassadors reflect our staff cohorts. So that's all I wanted to say. I'm happy to take any questions. Clearly, this is a look back in the previous year.
Okay, guys, there's been a number of suggestions come out of the previous conversation, which I'm sure you will pick up, Claire, along with whoever. And I think, Anne, you're the lead non-exec on Freedom Speak Up, aren't you? So I think between the two of you can think your way through the suggestions that were made. Jill in particular made several, but Rachel had some points too. Just think your way through how we maximise our support and our willingness and our engagement on this issue. Anybody else got anything at all on that? No. Okay, thank you very much. People plan, people partnering pledge. Mr. Smith.
Thank you, Alan. So we have here, I won't go through it obviously in chapter and verse detail, but we have here our disciplinary policy, which is in line with our people partnering pledge as part of the people plan signed off at the end of March, that we would review our policies and we would review them from a group perspective as opposed to individual trust perspective now. So this is the first one of those that we're looking at across the group, and it's reviewed. And the reason why it's first is also because of the learning that we've undertaken both locally at NGH and KGH, but also that we've seen nationally in relation to the impact of a disciplinary procedure and policy on individuals, and some of the Baroness Harding reviews as what they have all been taken into account in developing this new policy, in ensuring that whilst the policy is important and it's there for when things don't go right, it's also there to be supportive and less bureaucratic. So the number of pages has definitely been stripped down, and we've taken some good practice from other organisations in and across the country on that too. It's really important that we have such policies in place to support our colleagues. People very rarely come to work to make a mistake, and so it's really important that we're able to support them as and when and if they do so. The policy as you see it now is the policy. It's here for the board to review. It will go onto our website at the back end of next week, and what we have is a fantastic staff-side partnership at the moment in terms of developing the operational appendices that also sit behind this. So not policy documents, but operational appendices to work with that. It's not usual that we would bring this type of policy to the board, but based on the feedback that we had, particularly of the case that Baroness Harding wrote to us about a while back, it's really important that we have the opportunity to review our policy here at the board and make any comments as necessary. Thank you.
Okay, can I just check the verbs in that? Are we reviewing or approving this?
We're reviewing, we're not approving.
Okay.
We didn't want to set the precedent of approving these all our employee relations policies at the board, so it's another review.
Okay, thank you. Just to be clear for everybody. Okay, any comments or questions on this? No, not detecting any. I'm assuming everybody's happy with this. Okay, thank you very much. You can take that as reviewed and without adjustment or comment. Board Assurance Framework, Claire.
Thank you. This is the revised, remodelled and aligned with KGH version of the BAF going forward. It is in 2 parts. It has the group risks, of which there are 8, and then the NGH specific risks. These have all been reviewed and updated by the lead execs, ensuring there's no overlapping with the agreed group risks. I've also in the paper put a clear audit trail to show where the risks from the previous iteration in Q4 of the NGH BAF to make sure that no risks were lost in the change over. And it's here for the board to review. It has been through each of the committees in July, the risks specific to those committees, but happy to take any comments.
Okay, I think this is quite a, I think this is quite an important bit of paper. Well, everything that comes to board is, but I want to ask the committee chairs how this works for them in particular. So I'm going to, just to give you advance warning in this, David's got his hand up, so I'm asking whatever David has to contribute, that's fine, but I also want him to talk about it from the audit point of view. But then I'm going to come to Rachel, both to talk about the CPC and the Finance Committee, and then we'll canter through the other, Tom isn't here, so we'll do it with Anne and Jill, if that's okay, with people as the other committee chairs. Because I just think it's important that we reflect on whether this is working, and it's been through one cycle with you, so I'm not expecting it to be perfect. David.
Yeah, thank you, Alan. No, I'll come to the audit committee in a moment, because you understand I've only actually attended one audit committee meeting, and I'm in the process of talking to various stakeholders, mainly from the management team, as to how we take the audit committee forward, and especially with regard to the board assurance framework and indeed the corporate risk register. But my question on this, and I'm looking both at the group risks and at the trust specific risks, I see that finance is at the top of both of these. Well, in the context of risk scores, finance is the highest risk score. It's 25 at both group level and at trust level. Now, what does 25 mean? It's 5 times 5. What is the 5? It's catastrophic and highly likely. Now, this just strikes me to be, well, it's not intuitive as far as I'm concerned, sitting as a non-executive of a hospital where patient safety is probably my priority. And not only that, but as a hospital which is funded by the taxpayer, and surely we're not going to not pay doctors and nurses and have the basic infrastructure in place to give the best possible care.
Okay, thanks. I want to gather opinions on this. I'll come back to you, John. Obviously you're going to answer them, but I want to gather. If you want to have a word about audit committee now, David.
Yeah, I think this is one of the areas which we're going to look at, quite frankly. I do understand the purpose of the board assurance framework, and it's to make sure that the board is fully focused in on the risks that would prevent us implementing our strategic initiatives. As the audit committee, I think these are definitely items we should discuss, and it has to be there. They have to be looked at, and I also think they've got to be looked at in the context of the corporate risk register. And I think it's how we look at the corporate risk register and sort of build these into the board assurance framework, where I'm having an issue at the moment. And before the next audit committee, I'll certainly have reached some conclusions on that.
Okay, thank you for that. That's helpful. We'll come back to the other point you made, and any made by the other committee chairs. Rachel, from a group perspective, CPC, and then, and I appreciate you've only had really one committee of the finance and performance in your new role. So if you could just early thoughts on those.
I think my comments will probably apply to both committees, actually, that it's much easier now to review the risks. They're much clearer. And actually, we spoke yesterday, we did review this yesterday, and I think all the comments were very positive. And around, actually, when we did get to that section of the agenda, it made far more sense, because the points that we had covered previously to that item were all there in the risk register. And yeah, just very positive feedback to Claire.
Okay, thank you. Anne.
Yeah, hi. Yeah, much better. Definitely easier to navigate and to see where the real issues are. And I think at the last People Committee, Mark also presented the dashboard against the people plan, and it very much aligns with this. So we can see where we're on track, where we're not on track. So I think there is starting to be some good alignment. So I'm hopeful that this is going to make a difference.
Okay, thank you very much. And Jill, if you're in a position to talk about how quality saw it.
So just to echo colleagues' comments, we really liked it. We liked the format and the simplicity of it, and it was easy to read, so not a great deal to add. Okay,
like that's all pretty positive. I'm sure it's going to go through some more cycles, and I'm sure it's going to be improved further, if that's the right way to put it. Coming back to no other points raised, John, so you want to respond to that one, particularly about the rating for finance?
Thanks, Chair. So I think others have commented on certainly our finance and performance conversation yesterday. It was predominantly focused on the format, which I've got no issues with. I think it's very, very positive. I am still to go through a detailed review of those finance risks. I'm in more of a comfortable position that I know enough about them now that I'm able to take that view. So can I suggest that I take it offline with Claire initially? And we agree to update before the next cycle of meetings.
Okay, I think David will probably say yes to that. And clearly, I mean, it is very helpful just to remind people, you know, cataclysmic and likely to happen is what 25 is. So you just need to, because you then cannot possibly sit there and go, oh, well, that's very interesting. You then actually have to do something quite dramatic at that point, I would argue. And that takes us back into some of Stuart's risk scores in the past and some of the infrastructure things in the past, which perhaps didn't generate the actions or the clarity they should have. But I take the points, we're much better now. Simon, last word.
Thanks for the helpful comments, colleagues. Good to hear it's landed well. Clearly it's on an evolution, and Alan's right to call it out, and I think it's helpful to hear from all of you. 2 points. The first on, I'm interested as we evolve this journey further that we can satisfactorily describe to ourselves not just the risks really well, but what we're actually doing about it, because where we're talking about it and what we're doing. And that's a challenge as we go forward, not just for us in our group, but also as a system, because increasingly, I would just point out, we're moving towards a system framing of risks. And for those of you who've read or seen the HCP board papers, Claire and Richard and I and Alan have been working on some items to do with system risk. And it's important we think as we evolve this about how our risks feed into that. One reading on the finance risks, I just wanted to give David really. In many respects, you can read that, as you rightly did, in one of two ways. One of the reasons why boards pay attention to finance risk, obviously, is to prevent as well as to assure. So in the prevention space, the point I'd make is, although financial failure is really, really significant if it happens to a trust, the consequences of pursuing financial goals have been writ large across the NHS at the exclusion of others. So Mid-Staffs reminds us, when you pursue financial goals to the exclusion of quality goals, you end up in a really difficult space. So I think the way you framed the discussion, I entirely agree with. It's asking almost the opposite question around the risk sometimes. That's the helpful one, as you did there. And I'd encourage that debate to continue.
Okay, thank you, everybody. That's good stuff. Thank you, Claire, for the work. I'm assuming that's an old hand, John. Yeah, thank you. Fire safety report, Stuart.
Okay, thanks, Chair. The report covers from April to March, so April 20 to March 21. The purpose of the report is to give assurance to the board. There's been a huge focus on fire at all levels, especially our board, over the last 18 months. So the purpose of this report is to provide assurance that in relation to fire safety, we're meeting our statutory requirements, and it requests and recommends that the board gives approval for our Group Chief Exec Simon to sign the annual statement of fire safety. There's a lot in the report, obviously, because there's a huge amount of work that's been done. So I'll just draw your attention to some of the key achievements and key assurances we've got in place. So we've invested £2.5 million in fire safety. And when we're talking about a backlog capital maintenance budget of about 4 million, that highlights the significant amount of money we've put into fire. Our fire risk assessments have all been completed or redone this year in the new format, and they've been done by an independent specialist. So we've got that that independent scrutiny on those, and all the risks and all the actions of those are being managed and mitigated. All the fire systems we have on site, so whether it's the fire detection system, our misting system, sprinkler systems, dampers, etc., are all 100% maintained and operational. Our fire drills and fire plans, which are so crucial to our mitigations, 100% of them are complete, and 100% of them have been reviewed by our fire safety team. We've had regular meetings with our Northamptonshire Fire and Rescue Service. We've got much better links and support with those guys, and they've been supportive throughout all of this on our works, and they've advised and helped us. And yeah, our fire safety team done a fantastic job. We invested into those guys. That's not within the 2.5 million capital we spent, but we have increased the size of that team, and that's the way we've been able to provide all these mitigations. And there were 2 significant fire incidents during the year. They were both on the same floor in the same building, and they were both with a week apart, but they were very separate. So on the 8th of November, we had a small transformer fault in our ITU department, which meant we had to evacuate the ward early hours of Sunday morning. I know Simon knows all about it because we were having conversations early at Sunday morning. And then a few days later, on the 11th of November, Allabone ward, we had roofing contractors on the roof, and they managed to set fire to some of the felt. And again, the smell of the fumes meant we evacuated the ward. In both incidents, it sort of highlights the importance of our mitigations and those fire plans. In both incidents, the fire service commended us on our response, because both wards were quickly evacuated and everyone was kept safe. Just as well about the oversight of the management of fire. So we report monthly to the Finance Committee on fire performance. The review of the risk goes to ARC on a monthly basis. We've had numerous board reports and discussions over the 12-month period. We have Trust Fire Committee. We have an Estates Technical Fire meeting. And again, we have that regular review with the fire service. Just talking about risk, our score has gone from 25 down to 20, but we fully expect that to reduce again, and that's the piece of work we're doing now. The rationale, the methodology, how we do our risks in estates across the corporate risk, has always been we take the worst case scenario, and that's the highest risk. The piece of work we're doing now is trying to create a heat map. So, for example, we've got buildings that are brand new, Nye Bevan, for example. The fire risk in that building is not going to have the same risk of another building with 50-year-old electrical wiring systems in there. So that's the next piece of work for us to do. One, to look at that overall corporate risk, which I fully expect to come down from 20 into the 15. And then we would look at the heat map. So where are those key risks? And that will allow us to focus to make sure our mitigations in those areas are getting the focus they need. So Claire and the governance team are helping us with that as well. So just to wrap up, the report details the significant progress and improvements in insurance levels. The work's been supported by the local fire service, and we've had verifications through independent audits throughout. And it does recommend the trust. It does recommend the trust has measures in place to meet its statutory responsibilities, and recommends that Simon is given approval to sign off the annual fire statement. So I'll pause there and take any questions.
Okay, thank you very much. Anybody want to? We've talked a lot about this over the last 18 months, a lot of actions. Are you all happy with this? Yeah, you are. Good, excellent. Okay, thank you very much. I don't have any questions from the public. So I was going to do a little eulogy about Tom Robinson at this point, but he's not here to hear it, so I'm not going to bore you with it. You all know he's been very good as chair of our quality committee for the last couple of years. He's now the Pro-Vice Chancellor at Leicester, and as such, he's been nicked by Leicester Hospitals as their non-exec director. But we will have a replacement in due course, and Tom and I are having ongoing conversations about that. And we now have a Deputy Vice Chancellor on the board of Kettering Hospital as part of the University Hospital status. So those two will both add significant heft to our relationships with one of our major universities. This is also the last public board meeting for Eileen, who's been with us for quite a while, but it feels like longer, Eileen, because you were in Kettering on 2 batches before that. And you've been remarkably influential in making sure that the operational stuff continued, that the leadership of the 2 organisations in different ways, and also a big contributor to the development of the group model. So you are around for a bit longer, but this is your last public board meeting, so we ought to publicly thank you for what you've done for us explicitly since March, but before that as well in the other place. And there's a lot of hands indicators for that as well. Thank you very much. So the next meeting of the board will be at 9:30 on 30th September in the boardroom of Northampton Hospital or via Zoom, depending. I have asked Simon to plan on the basis that it will be face-to-face, but with always with the thought that COVID doesn't always behave itself, so it may well revert to Zoom. Thank you very much. I now ask you to pass a resolution that representatives of the press and other members of the public be excluded from the remainder of the meeting in regard to the confidential nature of business to be transacted, published for which would be prejudicial to the public interest. Thank you very much for passing that. You are almost on time, and as an extra special prize, you get the same length of time for your break. So 12:35 back, please, for the private board meeting. It is, I believe, on the same Zoom link, is it, Claire?
It's on a Teams
Sorry,
link.
it's not. It's on Teams. So if you could log out of this and go into the Teams link for 12:35. Thank you very much, everybody.